Hello. Hey, good morning, everyone.
People are go for meeting. Aga m eso ụzọ Chineke m nọgide ya ruo
gather for day or not.
Lose it.
Things to serve Jehovah also.
He has brought me into his banquet.
We'll miss it.
His love, his love.
Full. On the map with the mixing.
This is one stop. I want to do that back. Next salary. Mo ṣe fídíò ṣe ó padà. Àyè facilitator mi. Kano.
Have you a doctorate online? Your professional doctorate online?
Yes.
The Bluetooth device is ready to pair. The Bluetooth device is connected as
Okay, now how is your ability to get up with level and moving around the people?
Like for the first time. Hold on, I want to see. Hold on, I want to see. What did that match? What did that match?
Just for protection. And they are confident of your voice. Let's give it a try. Let's give it a try. You work with it. Hello? Relax. Hello? Check your WhatsApp. Check your WhatsApp. Check your WhatsApp. I sent you a message. Can you hear me?
Hello, bro. think the 50,000 is 5,000. Commission is power. Yes.
Hello? Check your WhatsApp. I sent you a message. Check your WhatsApp. I sent you a message on WhatsApp. Okay. Let's start.
Bate boy, Omar.
Nine o'clock.
Fine.
There is no lectures can come and go.
8,000.
So you go that the checks out. You will just do this 3 times before you start. I'm talking about this. So the first begging, really what it is, but once it's done, the second one to go very ending in the teeth, the local state good.
You don't have to take that.
You go,
This 12,500 is times 12 now. So I will be $26,000.
Yes, we're here. I think because we have a few minutes before we start. Dr. Adelu, thank you. We'll start exactly by 10. Dr. Adeluba, I hope you are here as a resource person, so that at some point I will hand over to you. I can't teach my teachers now. Ataniza and Delque, please, can you help me to yourself? Yes, Saidu Haruna. Saidu Haruna, please. There are many. Techno K15. Okay, Hafiz, let me just take over and mute them, then I will continue.
I think we can start, sir.
Okay, we have started. I just was asking if, the Oga himself is here too. So please, if you can, should I will maybe make you the what is it called, the host. I think Hafiz may not be there now, so I'll just make you the host for now. When Hafiz is ready, you can hand over to him.
Okay, sir.
Yes. So I think you are the host.
Okay.
Okay. So thank you so much, everyone. Apology for that little technical hitch. Okay, someone says there is no audio, please. Is it optional? Can you hear me now?
Yes, we can hear you now.
Okay, wonderful. Thank you. So did you get any part of my introduction?
It's very clear. I think it's network.
Did you get any part of my introduction? Because I've been speaking for 2 minutes. Okay, so let me just start from the beginning.
Really, I didn't get what. Maybe because I remember.
Okay, sorry, no problem. No, oh, okay. I spoke for about 2 minutes. I think I was muted then. No problem. Okay, thank you so much. Thanks to everyone for joining us today. This is the first module in a series of neuro rehabilitation workshops that we will be having. There are going to be about 4 or 5 modules. And this first one is on principles of assessment and rehabilitation of neurological conditions. We are not going to be dealing with the actual assessments or looking at treatments that will be given to patients. But what we will be looking at are the principles. What are the guiding principles for the selection of assessment procedures that will help us to reach a physical diagnosis? And what are the guiding principles that help us to select what treatments, rehabilitation that we give to the patients? So this is what we'll be looking at. Next week, we are going to look at radiological investigations. Although they are part of the principles, but we thought it is something that many of our colleagues have little difficulties with because of the nature of how radiological investigations are done and the interpretations. And therefore, next week, we are going to deal with that, but just know that they are also part of these guiding principles that we are supposed to look at. We just picked that to have it as a workshop for a whole day so that we can be able to see the principles of how to read the radiographs and how to interpret them, and how can we be able to make use of that in the process of making a physical diagnosis, not a medical diagnosis. And then after that, we'll then get into looking at the conditions. And I think the conditions that we have selected this time around are stroke, spinal cord injury, and Parkinson's disease. So these are the things that we'll be looking at in the next few weeks. But as I've said, today is about the principles. So before we start, I just want us to have a little interactive session. In our assessments of neurological conditions, what sorts of things do we assess? And what I'm asking is not about the principles or what is there in books, what we have read, what we know. I want us to be very honest, to just state the clinical features that we usually assess in patients that have neurological conditions. Or possibly they don't have neurological conditions, but we have suspected during the first part of our screening that they may have a neurological system problem. And we want to now assess to see what's risk factors, symptoms, and signs, or symptoms and signs of neurological conditions that are there that will help us to be able to make a physical diagnosis in the area of neurological rehabilitation. So what sorts of assessments do we do? What sorts of clinical features do we assess to identify if they are there in the patients? I just want us to have a baseline. So this is about, because all these workshops are aimed towards changing our practice. So after the workshop, what's going to happen? If in the next 2-3 weeks, we come to have another workshop, and I ask, what sorts of assessments do we do? What we are expecting is that we are going to have more assessments than what we used to do. So please, just want us to put down what we do, not what we know that we should do. So what do we do as part of assessments for wonderful, someone has already posted assessment of muscle power. So can we please go onto the chat forum and just put down the assessments that we do? Motor impairment, assessment of muscle power, wonderful. I know we have many people that are on this, so I will be expecting to have many responses. Neurological status, motor, sensory. So when we do motor and we do sensory, it will be good if we have the breakdown. So what sorts of sensory do we assess? What sorts of motor assessments do we do? Sensory impairment assessments. Get pattern, wonderful. Tone, cognition, good. Dermatomes. Neurological assessment of deep tender reflexes, balance, good. Wonderful. Assessment of spasticity, yes, spasticity. Cognitive proprioception, proprioception. So this is breaking down the sensory into parts. So proprioception, can we see more sensory assessments apart from proprioception? We have reflexes, we have balance, coordination, ADL, wonderful. ICF, very important. So balance, reflexes, cranial nerve abnormalities, very good cranial nerve. Balance and coordination. Good. Quality of life, yes, quality of life. So looking at participation. Risk factors, subjectively and objectively, motor, sensory, and balance. So even the balance, we can break it down. What types of balance do we assess? Functional assessment, yes. Looking at activity and possibly participation, very important, the ICF. Okay, so this is wonderful. This is wonderful. We do static and dynamic balance, exactly. Static and dynamic balance, very good. Dynamic and static balance, yes. Okay, wonderful. That's great. So I'm just going to, I shared this slide so that we'll see hand grip, yes, so that we'll see what the module, the title of the workshop. I'm on house family. Expect to link me in that message either for APT.
Obi.
Headache, vomiting, slurring speech, etc. Okay, so looking at systems review, yes, systems review. Okay, so let me just quickly share a document. What I'm going to do today, because Dr. Lawan and Dr. Abba will be taking many of the parts of what is there in the content, and therefore I'm going to just give a total summary and a guide as to why we need these principles. So this is what I'll be focusing more on. So please, Dr. Lawan, Dr. Abba, are you with us? Dr. Jibril Samani or Hafiz, please, if they are here, fine. If they are not here,
Yes.
whenever they,
We
okay,
are
are they,
here.
both of them?
Mm.
Okay, wonderful. Thank
We
you.
are here.
Thank you. Okay, wonderful. Thank you. So I'll just give a summary, and then you will take over and give more details. Last time we did this workshop, I used only pictures because I thought the visual will be better. But people asked for text that will help them to understand the figures that we have there. Now, why I asked about what forms of assessments do we do is because the manifestations depend on the area of the nervous system that is affected. So the manifestations, which are the clinical features, and these are the things that we assess. We have talked of sensory, we have talked of motor, balance, cognition, wonderful. We have touched on the domains that we usually will have manifestations or clinical features when we have neurological impairments or problems. But what you see will depend on what area of the nervous system or what part of the nervous system is affected. And that is why next week, when we look at the radiological investigations, you will see that there is a correlation between the manifestation and what you identify as the area of the nervous system that is affected. If you have an area of the nervous system that affects a particular function, then it is that function when you assess that you are going to see as having a problem. So I've posted this on the WhatsApp group that you're going to see. It's a paper that was published on motor control of functional tasks. It's looking at how parts of the nervous system work together to bring about movement. And when a particular part of the nervous system is affected by disease or injury, what manifestations are you expected to see? So as I've said, I'm just giving a summary, but I will just go through to quickly just mention some of those parts and how injury there could lead into movement impairment. So you have mentioned sensory information. So one of them is the visual system. So usually incident light around the visual field stimulates the receptors in the retina, and the image of the main object of interest falling on the central fovea. So this is how you see things. This is how you see things in the environment. And when you talk about movement, it is about interaction with the environment. How do you move? You want to pick a pen on the table. You want to pick a cup to drink. You want to kick a ball. All these are activities of daily living. Aim to integrate the individual back to doing them in their communities, in their societies. And therefore, if someone has a visual problem, then they can't be able to even locate the object. And if they can't locate the object, what that means is that they can't interact with the object. And therefore, for movement to occur, there is need to have visual system that is normal. And this visual system can be central vision or it can be peripheral vision. And for the central vision, you want to be able to see something centrally, but apart from that, you want the acuity. Because if you can't see it and it's blurred, it's still going to be difficult to manipulate that object. And that is why we do test of acuity. Another thing that we do with vision is the test for peripheral vision. And that is what is called the visual field. As I'm looking at someone straight ahead, I suppose to see what's happening in the periphery. So as I'm looking at you straight ahead, if someone is standing by my right, I should be able to see them without turning my eye or my head. So if I can't be able to see, then I can't multitask. I can't be speaking to you and reach out to pick an object by my side on the right or on the left. And that is why we do the test of visual field. So the patient sitting, you put your arms up their eyes, and the patient should be able to say, this is the number of fingers that you have put up. That means they have peripheral vision. And that means they can be able to interact with the environment. While they are speaking to someone, looking at them into the eyes, they can be able to reach out and pick objects without turning their eyes to look at them. It's part of activities of daily living. So if you look at the issue of vision, you will see that, number one, the periphery. So if you have the nerves that pick information from the eyes and takes it to the brain, then you are going to have a problem with vision. If you have a problem in the primary visual cortex, which is possibly shown in this picture, yes, this part of the brain. Don't worry about the drawings. I've tried to put them in just such a way that we can understand the locations, but it does not really depict exactly how the brain may be. So if you have an injury affected, and vision will also be affected. Sorry, it's breaking. It's breaking. Okay, I can change the network. Usually, it's the network. So please give feedback so that I won't lose anyone. So that's the area, primary visual area. So when the object location is picked, it goes there. But in that primary visual area, it has two streams. It has two streams. And those Yes, apology. The network was bad. MTN. So I hope you can hear me now. I think I'm back. Yes. So okay.
Better.
Yes. Okay. Wonderful. So please just give feedback as breaking. Sorry. We're discussing the issue of the systems. So because we are talking of principles of assessment. Now, why is it important for us to assess vision? We have now had that number one, for an individual to interact with the environment, they need to locate the environment. They need to locate whatever it is that they are going to interact with. And one of the information required is about the location. But another information is about the nature of the object. So if you have to pick a needle, the type of movement that you need might be only for the brain to instruct only to. But if you are trying to then the grasp is going to be different. And therefore the nature of, because if not, it will be difficult. Patients may have difficulty with either the location or the object. And that is why different domains of nerves and how to assess them. You'll see a number of color, the peripheral, where you ask the patient to continue. Eyes move in all directions normally, because either from the brain or from the periphery, have the problems of movement of the eyes. If the working properly, either peripherally or the information, very important to assess. Vestibular system. The position and movement of the head movements, and to provide very important to assess the forward and back of the head is what the brain is able to pick up from the vestibular system. And it now sends the information down through the vestibulospinal tract to go maintains you in an upright position. It is not under voluntary control, and therefore it helps with balance. Is that when you are looking at an object, are still focusing on the object. It is the vestibular system that helps you to be able to maintain your gaze. There is a test that is called a nystagmus test, spontaneous nystagmus. You need to keep looking at the finger. If the patient is But if there is a problem with the vestibular system, you'll see small oscillations of the eye. The eye is not able to fix its gaze on the object that the patient is looking at. And that shows that there's a vestibular problem. And just imagine someone that is reading a book, but they can't control the movement of the eyes across the lines of the book that they are reading. That is going to serve as part of what we need to assess to be able to know why our patients cannot be able to do activities of daily living. This is the vestibular system. I will leave you with this document to read through and see more information there. So you have from the vestibular system down to the vestibular nuclei, and it goes down. That is for the postural adjustment. But from the vestibular system, when movement of the eyes are controlled, it comes down to the vestibular nuclei, and then it sends information to the eyes to help with fixating gaze on the object that you are interacting with. Now, another important sensory issue is the proprioceptive system. In the joints of our body, we have proprioception is the information provided to the CNS by sensory receptors in muscles, tendons, joints, or skin about the position of the body or its parts and of the force, direction, and range of movement. If I want to reach, there won't be any movement because I don't know where the position of my arm is in space. And therefore, oh, is it still breaking? Oh my goodness. What do we do now? Is it so serious that you can't understand me at all? Please just give me feedback. I may need to either change location. Or it's fair. Okay, so if you can understand me, let me continue and hope that it will get better. Thank you. Continue. Okay, wonderful. Thank you. So proprioception. I want to reach for an object. Depending on the location of the object, there's going to be a different type of movement that you are going to have. If your hand is on your shoulder, you are going to have more abduction, and you have external rotation, you now reach the object. But if your hand is placed on, say, the backrest of the chair like this, and you are reaching for an object that is in front of you, you are going to come in with a different pattern of movement. And therefore, for the brain to instruct the arm to move, it needs to know its own position in space, and also the position of the object that you are going to reach out to. Some patients don't move, not because their muscles have a problem, but because their proprioception is affected. And that is why it's very, very important. Assessment of proprioception, very, very important to be able to identify, is it the muscles or is it proprioception that is making the patient not to be able to move? So that information goes to the somatosensory area. So the midline of the brain to the back, because we talked about the primary visual area around this area earlier, this is where the somatosensory area is. So if you have a problem peripherally that affects sensory nerves or the dorsal column at the back of the spinal cord, you may have a problem with proprioception. But the problem that the patient may have may be centrally located. So if you have a problem in this area of the brain, then you are going to have proprioceptive, mean that the patient will not be able to know the position of their arm in space. How do you assess that? Ask the patient to close their eyes. You move the joint and you ask them to replicate it with the other side. Or if both sides are expected to be affected, then ask them to give a particular range. Say you have 0, you have 90, you have 180. And say, I'm going to place your arm in one of those 3 positions. I want you to let me know in what position it is. So these are ways of assessing the proprioception. And if you think it has a problem, there is an intervention that we give as physiotherapists to be able to help the patients recover their proprioceptive impairment. So these are some of the sensory impairments that you can have. Then, of course, we have said this information will go to the sensory area. For proprioceptive area, while for vision, it goes to the primary visual area. But each of this information is separate. But for the brain to be able to now have the arm move to an object, you need to synthesize the two information. And that is why the two information will go to, I'm not sure if I have the picture, central control. Okay, I have the picture. Remember, from the visual area, the somatosensory area, the information will now go to the front of the brain, which is the prefrontal cortex. It is in this prefrontal cortex, in the front of the brain, that the synthesis occurs. That is where the brain will now say that, look, the position of the arm in space is here. The position of the object is here. And therefore, the brain will now understand the two at the same time, not separate. And then you will say, okay, if we need to go to this, this is the movement that we need to have. So that prefrontal cortex is important for information processing. And that is why when people have cognitive problem, they can have the individual information going to the brain, but because it cannot be synthesized, and that is why it's important to assess cognition, information processing. Another thing that happens there in the prefrontal cortex is what is the memory. The memory. You have done an activity before with information about the position of the arm in space and that of the object. Whenever you do that activity, you make errors, you update the errors. And the more you update the errors, the more the prefrontal cortex keep the updated version, so that when next you are going to move, it will bring it out and use it as a template, and therefore you have accuracy. And that is why for table tennis, you find out that if they do it over and over and over, they become have more precision in doing those things, because the prefrontal cortex keeps that information updated all the time. So people that have problem in their prefrontal cortex, so you have the patient has an accident, and in the MRI or CT, you see that the problem affects the front of the brain, which is this prefrontal cortex. Then that shows that the patient may have problem with information processing, may have problem with recalling previous templates or blueprints. And then you see the patient, whenever they do an activity, they make errors. When they come to do the activity again, they will make the same errors again. And that is the problem that the prefrontal cortex gives. So knowing what these areas do will help you to be able to know what to assess. It will help you to be able to, when you make assessment, to be able to infer what part of the brain has been affected. Please, if I'm not carrying, I don't know if I'm too fast or the explanation is not clear, please just give me feedback, because this is one of the very primary things that we need to understand that will help us to be able to assess patients more comprehensively and more robustly. A lot of information, and I have to compress it and give it out, but still trying to give a lot. So please just give me feedback if you are not getting the explanations. Yes, so that is what. Thank you so much. Wonderful. So very important now to assess sensory, and the sensory we have said we should assess visual, and under visual, remember we said acuity and possibly even color, because when you will be looking at them and he can't be able to know which one is blue, which one is red. It affects movement. And for us, whatever affects movement is part of what we are interested in. We said proprioception. You now go to the joints and you do the assessment to say that, okay, move your joint. Okay, I've moved your joint. Replicate it with the other side. Or I've moved it to either 90, 180, or 0. Tell me which one it is. then you'll be able to know which joints have proprioceptive problem. For the vestibular system, we have talked about the nystagmus, and there are other assessments for the vestibular system too. So for cognition, mini mental state examination, it has which you can assess the viability of the prefrontal cortex. So by the time the prefrontal cortex, which is this wide, synthesize the information, sensory information from the proprioception, from the visual system, from the vestibular system, the next thing is that what patterns of movement are there available for me to choose from? That's what is called the degree of freedom, meaning neurologically your movements. There are so many degrees of freedom. There are so many different combinations of joint movement. But so it is the premotor area, this area of the brain that is just behind is the prefrontal cortex. Then this area just behind the prefrontal cortex is called the premotor area or supplementary motor area. So if in your radiological investigations, you realize that in the area of the prefrontal cortex, what is it that the patient will have as a deficit? Now, one of the problems, what the function of that area of the all the possible patterns that are available. How do I move to that object? Do I go like this, or do I go like this, or do I go like this? There are so many different patterns. That the patterns. But the problem is, if you have 10 or 20 different patterns that are possible, how do you choose one? And this is the responsibility of the basal ganglia. This is the basal ganglia. So if you have this particular area is affected, and when we come to do the radiological investigations, you are going to see how to take sections of the brain so that you'll be able to locate at what area of the brain do you have a problem, so that you'll be able to know what deficits are you expected to have. So the basal ganglia is the one that chooses one out of those many different patterns that are possible from the premotor area or supplementary motor area, which is this premotor area, or sometimes called supplementary motor area. So let's see what happens in the basal ganglia using a picture. Ganglia very well. You know that it has the striatum, it has the substantia nigra pars compacta, and then other areas. I'm not going to go into details of all this. All I want to say is that from the cortex, that's the premotor cortex, or the supplementary motor area, you now have 20 different options. So those 20 different options are going to be sent down to the striatum. This is the striatum. When the 20 come, then the substantia nigra pars compacta, which is here. And I think this is what we are familiar with. If there is no dopamine, then you are going to have bradykinesia, you are going to have rigidity, you are going to have the tremors, and you are going to have postural movements. How do they come about? Because of the problem of the basal ganglia. The substantia nigra pars compacta is supposed to release dopamine, and it now goes to the striatum. It's now going to work on those 20. It will select one and send it down through one pathway back to the thalamus and to the brain to say this is the one that is the most perfect to do that activity. Then the remaining 19 out of the 20, dopamine will work on the striatum so that all those 19 will now be inhibited, so that through another pathway, it will go down to the thalamus, and then it will go back to the cortex to say, don't use those 19. That one that the striatum select due to the action of the dopamine that comes from the substantia nigra pars compacta that has been selected, that's the one that you are going to use. And therefore the brain would say, wonderful, out of 20 with all the confusion, the basal ganglia has selected one pattern. And when I say pattern, I mean individual pattern. So let's say, for example, shoulder flexion, shoulder abduction, elbow extension, wrist extension. These components put together forms a pattern because that is how the arm gets to the object. So one has been selected. All other patterns will be inhibited. This is the work of the basal ganglia. And that you will now ask, why is it that people with basal ganglia problem have bradykinesia, slowness in movement? The reason is, if, for example, you are working on a path to a village, and the path now becomes of that path, you will have to stop to start thinking, which of the three should I pick? That will slow your movement. But if someone is working with you from the village and he says, take the straight one, not the right or the left one, when you get to that point, you know you don't need to slow down your movement. You advance as fast as you are moving to be able to get to that village because someone has selected one out of the three for you, and therefore you move fast. And that is why when you suspect that there's a problem with the basal ganglia, one of the things that you assess is bradykinesia. There is a tool that is used for that. When we come later, we'll discuss all those tools where you say, okay, you want the patient to tap, keep tapping so that you see if the movement will be slowed down, or you ask the patient to do pronation supination, pronation supination, pronation supination. If you are testing the lower limb, you are asking the patient to keep putting the heel on the ground as fast as they can. And that is how you'll be able to see if there is slowness of movement or not. There's something with how this affects the tremor, the rigidity, and all that. This is the function of the basal ganglia. But the issue is, the basal ganglia has selected one out of many. But we know when we all the joints don't start to move at the same time, and they don't aim the movement at the same time. If you want to reach for an object, usually the proximal muscles will start to move so that it will take the hand to the object. It is only when the hand gets to the object that the hand muscles now begin to contract to open the wrist to handle the object. The moment you hold it, you stop the movement at the wrist, and then the proximal muscles will now begin to move. For example, you want to eat. By the time you get to your mouth, that is when the hand muscles will now come back to start to move so that you can be able to put the food in your mouth. So this is coming in. I hope you can hear me. So what I'm trying to say here is that not all muscles begin to move at the same time. They move as at when the need arises. But the pattern has been selected. So what part of the brain gives the timing to each component of the pattern to move as the need arises during the whole movement? Please, can those that are not muted mute themselves, please? Or the coordinator, please help us mute. Yes. So it is the cerebellum. It is the cerebellum that does that function. Just trying to get the picture. So the cerebellum, maybe the location might not be perfect, but at least you can see that there is cerebellum. We have the basal ganglia. It has selected one pattern. The cerebellum will now give timing to each of the components. It says shoulder flexors, start to move now. Okay, stop now. Finger, wrist flexors. This is the time that you are going to moving. And that is why if a patient has a problem with coordination of movement, because the cerebellum cannot give timing to each of the muscles that are components of the pattern selected by the basal ganglia, then you are going to have a problem with movement. And that is what we call the coordination. And I think some of you have posted that you assess coordination. When you have a problem in the cerebellum, it cannot give timing to each of the components that we have. So by selected, timing given to each of the components, then you will now go back to the motor area. The motor area is just behind the premotor or supplementary motor area. Remember the premotor or supplementary motor area, that is, I think, the area that you called area 6. I know area 4, motor cortex, area 6, the premotor cortex, if you remember our anatomy, but I won't bore you with anatomy too much now. So that motor area is the one that's going to say, well, I know the pattern, I know the timing of each of the components of the pattern, and the motor area is in a form of homunculus. There are parts of the motor area that handles the upper limb. There are parts that handle the lower limb. There are parts that handle the head and the trunk and all parts that need to move. So if it's in the hand, then the area that controls the hand will now say, okay, let's send impulses down to the hand to implement that pattern selected by basal ganglia and the timing given by the cerebellum, and it will now implement. How does it implement? It sends impulses down through the corticospinal tract to the muscles, and the muscles now contract. And that is why if you have a problem in the motor area, then it is muscle contractions that you have as a problem. So it's motor, not sensory. So how do you assess motor? Our Oxford grading system, depending on what the source of the problem is. If the problem is in the periphery, after the motor area has sent the impulses through the corticospinal tracts, at the roots, a peripheral nerve leaves. If you are going to use the Oxford grading system to assess. But if the problem is in the brain itself, that motor area that we have discussed, if the problem is in the motor area itself, then it is not Oxford grading system that you are going to use, because the individual muscles are not affected at all. What is affected is the ability of the brain to send impacted. And how do you assess motor activity with central affectation of the brain? Is either Bronstorm recovery assessment, or Fugl-Meyer assessment. So Bronstorm recovery assessment or Fugl-Meyer assessment. These are the assessments that you do if the injury or disease is affecting the
I can't hear you. I can't hear you, sir.
Yes, a call came in. Yes, a call came in. I'm sorry. I wanted to get a modem so that calls will not be disrupting the discussions. So I'm sorry. I've disconnected. Yes. So finally, just saying the assessment you do for motor, and I'm emphasizing this because I see physiotherapists using Oxford grading system in a patient that has stroke or traumatic brain injury that has affected the brain centrally. When you do that, you are going to have a problem. What problem will you have? You have an abnormal synergy. The muscles can each move individually, but what is affecting them is that the whole limb has been held in a particular pattern, and therefore there is no way you can on its own. An Oxford grading system is assessing individual muscles separately. Therefore, don't use Oxford grading system to assess muscle power in patients that have central nervous system problem that leads into an abnormal synergy, meaning the limb is held in one particular pattern and individual joint movements cannot be isolated. You can only use Oxford grading system in those patients when they have reached a stage that they can have individual joint movement. But in as much as the limb is held within a particular pattern and individual joint movements are not possible, then you use Bronstorm recovery assessment or Fugl-Meyer assessment or any of the other synergy assessments. This is what is more proper. inside the basal ganglia, selection of pattern of movement was not clear to me because it was breaking. The basal ganglia, when the premotor area or supplementary motor area selects, say, 20 out of, so select 20 patterns that are possible. The basal ganglia is the one that is going to now pick one out of the 20. 20, when the information from that premotor area comes to the basal ganglia, the first point of contact is the striatum. You have the substantia nigra pars compacta that has dopamine there. It will now send the dopamine to the striatum. And the striatum, the dopamine will work on the striatum to be able to now select one out of the 20. It will now send it through the thalamus back to the cortex. The remaining 19, the dopamine will work on the striatum to be able to inhibit the remaining 19 out of 20, and it will now send that through the thalamus back to the brain to say that don't use those remaining 19. And therefore, the substantia nigra pars compacta plays a major role because of its storage of dopamine. That is why if you don't have dopamine in the basal ganglia, you are going to have a problem with selecting one out of many. And if you can select one out of many, the brain is going to be confused. Which one out of the 20 should I'm just saying 20 as an example. Which one out of the 20 should be selected? And if the brain is confused, can't select one out of many, then you're going to have slowness in movement, because until one is selected, then you are not going to be able to do the movement fast. And that is why physicians or neurologists will give levodopa or any other drug that contains an external input of the dopamine to the system so that it can continue to work on the striatum to select one out of the many that are there. Can you please explain what assessment measures can be taken if the limbs are not movable in place of the Oxford Moss? I said Brøndstrom recovery assessment. Brøndstrom recovery assessment or Fugl-Meyer. Brøndstrom recovery assessment or Fugl-Meyer assessment. So these are for synergy. And for the basal ganglia, it is called UPDRS, Unified Parkinson Disease Rating Scale. Unified Parkinson Disease Rating Scale. But for the assessment of synergy, it is, I've posted them, Brøndstrom Recovery Assessment or Fugl-Meyer Assessment. I'm going to show you a website where you can get them and get the description of how to use them and even find out if they are, they have psychometric properties, validity, and reliability. The site is called Rehabilitation Measures Database. I'm going to show you the database, but in case I'm not able to, because I'm running with time to allow Dr. Lawan and Dr. Abba to come in. So rehabilitation database measures or rehabilitation measures database, you can be able to get as many outcome measures as possible there. So I think this is, I've already explained centrally and peripherally how the nervous system works to bring about movement. You can get more details using this article. There's even another summary at the end of the whole thing where we talked about the parietal cortex, the sensory, and then the prefrontal cortex that synthesize, and then you have the premotor area that selects the patterns that are available, and then you have the basal ganglia selecting one out of the many patterns. Then you have the motor cortex implementing after the cerebellum has given the timing for each of the movement. And then from there, you now have the peripheral structures, the roots, the nerves, and the neuromuscular junctions, and the muscles themselves, at the end of the day, give rise to a movement coming up. So if you have a problem in any of these sections, then you are going to have different manifestations. And your assessment is going to show what manifestations, and then you'll be able to come back to say, no, from this assessment that I've done, is the parietal cortex, is the prefrontal cortex, is the basal ganglia, is the premotor area, cerebellum, motor cortex, periphery, and all that. And your treatment is going to depend on what area of affectation you have. For example, a patient that has a problem in the peripheral nerve or in the muscle, you can give them electrical stimulation or strengthening exercise. But a patient that has a problem in the motor cortex, if you give them strengthening exercise, electrical stimulation, the brain will not even know you have done anything. So what is best for the brain? Functional electrical stimulation, neurotherapy, transcranial direct current stimulation, virtual reality. These are all interventions that you can give that can target the brain through what is called neuroplasticity. And this is one of the things that Dr. Lawan or Dr. Abba will discuss later in the day. So let me just quickly leave this because I've already taken almost an hour, and I was thinking I would do everything that I was going to do within 30 minutes, less than 1 hour. But let me just quickly. So is there any question? I believe it should have been more interactive, but because of the timing, sometimes it does not allow you to have the interactions, but the interactions are important. Are there any questions or comments that you want to make on this particular aspect that we have looked at? How has your practice been? Is there anything from these explanations that you see that you think is important for you to consider as you practice assessing neurological conditions? So maybe just in a minute or two, can we just have comments on that? Okay, can't see any comments, any hands? Okay, question 1. Can we explain the concept of feed-forward and feedback control in the context of the interconnected, interconnected loops? How do the interconnected loops contribute to non-motor functions such as cognitive and emotional processing? We have a section going forward that is going to discuss this issue of feedback, feed-forward, and feedback. So when we get there, we are going to discuss that. But the whole issue is that when you have an activity that is going to be done, for it to be accurate, then you need to have feedback to the neurological system that it has been done all right or not, so that there's going to be correction if it's not going on well. And these areas of the brain, having the sensory system, because as you are doing the activity, you have the visual system still looking at the surroundings. So the brain has given instructions that you should move towards the object, but you deviate. It is through that feedback and feed-forward system that the brain is able to receive more information that it needs to adjust and move towards the object that's supposed to move towards. So all this are the interactions of the sensory system, the motor system, and the postural adjustments. Because as you are doing the activity and you begin to lose balance, instead of going towards reaching the object, you rather stop and maintain your balance. And it is through this feedback that you are able to maintain your position while at the same time continuing to do the activity that you have started. Does that mean the assessments of muscle power in neuro rehabilitation, we should not use Oxford muscle grading? I said it depends on the level that you have the problem. If the problem is at the peripheral level, so you have a peripheral nerve injured, you have a neuromuscular junction affected, or you have the muscle itself affected. Please, can we mute?
This one.
Please, can we help mute? Olufela and Reuben. Reuben, Kate, please, can you? So if these are the areas where you have the injury or disease affecting the nervous system, it is very okay to use the Oxford muscle gradient. But if you have a stroke, you have a traumatic brain injury, you have whatever disease or injury that affects the brain, the motor cortex in the brain, and as a result of that, you have an abnormal synergy, and it is at a stage that the abnormal synergy has not broken into components that you can have individual joint movement. Don't use the Oxford muscle grading system. The Boston Recovery Assessment that I mentioned earlier, it has 6 levels. In level 1, 2, 3, you have the movement within the synergy, and therefore you can't have individual joint movement. But at level 4, 5, and 6, especially 5 and 6, you are beginning to have some level of individual joint movement. You can use Oxford muscle grading system at level 5 or level 6. But if the patient is at level 1, 2, 3, don't use Oxford muscle grading because it's a central nervous system problem and you have an abnormal synergy. But if you have the problem in the peripheral nerves or in the neuromuscular junction or in the muscle itself, then you can use Oxford muscle grading because it is affecting individual muscles, not linking all the muscles into one pattern, which cannot be broken into individual joint movement. Are there interventions you can use to help patients with cognitive cognitive impairments apart from cueing? Cognitive impairment there are, but the main professionals that treat cognitive impairment are neuropsychologists. Neuropsychologists, we don't have them in Nigeria. I was in Germany, sometimes stayed there for a month, and I worked with new physiotherapists, occupational therapists, neuropsychologists, and speech therapists and audiologists. And that was where I saw how brilliantly they can use those contexts of cognition, the attention, the memory, the synthesis of information, and other things to be able to treat cognitive impairment. But if you look at the way we treat patients, even if we are not targeting cognitive impairment, cognitive impairment gets better with our treatment. Why? Because if you ask a patient, I want you to reach out to touch this object, and then after that, I want you to switch this light. There is a cognitive component to it. So even though they are not targeting the cognitive impairment, but it is being resolved because the activity they are doing involves cognition, and they are doing it with many repetitions, and therefore the prefrontal cortex that has an injury can begin to resolve its injuries as a result of the repetitions that you do in presenting the cognitive challenge to the patient. Yes, okay. I did not get assessment protocol for basal ganglia. Assessment protocol for basal ganglia, because one of the reasons that you have basal ganglia problems, or maybe the consequence of a basal ganglia problem, is that the basal ganglia cannot select one out of many patterns. So if you can select one out of many, the brain will be confused. When it comes to do the activity, it wouldn't know which of the many options it should implement. And therefore, there's going to be slowness in movement. There's going to be slowness in movement, meaning the patient will want to move, but it will be slow. Sometimes they get stuck in one place. That is what is called freezing of gait. Now, if you want to assess the slowness in movement, you use the Unified Parkinson's Disease Rating Scale. The items there will say, I want you to tap your index finger and thumb, and you keep doing like this. A normal person that does not have basal ganglia problem will continue to do it very fast. But in a patient that has basal ganglia problem, what you'll see is that they will start fast and then it will become slow. Either the amplitude reduce or the speed reduce. If you ask them to do pronation supination on their lap, they will start fast, but at a point, they will be doing this. It will be slow because the brain is having difficulty selecting which one to have. Of course, for the tremor, you are going to see the tremor, and there is a way you assess it. Either the speed with which it moves or the amplitude with which it moves. There are assessments like that. It's called the Unified Parkinson's Disease Rating Scale. Will be right at the initial time in a patient with CVA to be rated with muscle power 0 for upper and lower limbs. If you use muscle power in a patient that is within 1 to 3 in the Prostrom recovery assessment, and you say, raise your hand, and they are not able to raise the hand, your assumption is that the muscles cannot move, but the muscles can contract, they can move. Why they are not moving is because the brain is affected and everything is locked into one particular position like this. And therefore, if you do that, it's going to give you a false information that the joints cannot move, but it's not the joints that can't move. It is just that the arm is held in that abnormal synergy. I didn't have time when I was explaining the anatomy. I would have explained to you what brings about that anatomically. Maybe let me just quickly do that if I can send the message within a few minutes. The motor cortex that we discussed earlier, that sends impulses down to the periphery. One pyramidal cell, because that's why it's called the pyramidal area, because the cells in the motor cortex, they are called pyramidal cells. One pyramidal cell, when it fires, it does not send impulse to only one muscle, because the brain understands functional movement, not a single joint movement. And therefore, when one pyramidal cell fires, it sends impulses down, and the impulses from that nerve will now bifurcate. One nerve will go to the shoulder, one will go to the elbow, one will go to the wrist. Of course, because you need many impulses and many branches to supply the muscles. That is why you have the motor unit. The nerve and the number of muscle fibers that it supplies determine the strength of the contraction. Now, if you have that pyramidal cell fires and it sends impulse, you have other nerves come from that particular nerve. One goes to the shoulder, one goes to the elbow, one goes to the wrist. Then maybe another combination will be one go to the shoulder, one go to the elbow, if it's a movement that only requires movement of the shoulder and the elbow. And therefore, when you have a problem with the motor cortex, you don't usually have a problem in only one joint. You have a problem across joints. And that is one of the reasons. There are more explanations, but I don't have the time to be able to give more. But this is just simple way that I can put it, that when you have a central problem, even joints that don't have problem will be forced to come together and stay in one particular pattern. And that is why you don't use the Oxford grading system, because with Oxford grading system, you are assessing individual muscles. But in this particular situation, the individual muscles are locked into one pattern, and there is no way you can break it until you treat the brain using those interventions that I've mentioned. And then at a later stage, when you have individual joints able to move, and that is when you can be able to use the Oxford grading system. Okay, so I think I've answered all questions. I'm very happy. I really prefer it this way because that will help me to be able to know if you understood what I presented. And from these questions, I can see there is understanding, only that there is need for clarifications. Thank you so much. So I'm going to quickly, Dr. Lawan, Dr. Abba, I'm so sorry. I know I'm supposed to have given back to you at this point. What I did was I asked Dr. Samani to let me know some of the areas that are not part of the presentations. And I just thought, let me cover those areas instead of giving the summary. But if you tend to give this, then maybe there could be an emphasis on what I've given already. So let me just quickly go through this. As fast as I can. If it's too fast, just let me know so that I can adjust. So clinical syndromes in neurology. This is part of what I've already explained in my general explanations earlier this morning. So areas of the nervous system have distinct functions. I've said this. Injury or disease to each area could elicit different manifestations. I've said this. Now, understanding the areas and their function helps to infer what area is injured or diseased after assessment and vice versa. Meaning, understanding the manifestations and seeing the manifestations will help us to be able to infer what area is affected. And that's why this is really very important. Now, let me ask this very quickly. Maybe you have read it or maybe you have seen it. What forms the central nervous system? What forms the peripheral nervous system? Very quickly, if it's possible for us to do it. As quick as possible. What forms central system?
System is formed by the brain and the spinal cord. The brain and the spinal cord.
Okay, forms the central nervous system. Okay, what forms the peripheral nervous system? Brain and spinal cord. Brain and spinal cord. So, okay, wonderful. That's why I asked, because these syndromes is important to know exactly what forms central nervous system and what forms peripheral nervous system. There is something that is part of the brain or the spinal cord, but it is not regarded as a central nervous system. And that is why I asked the question. So let me show you. The central nervous system, the brain, except the cranial nerve nuclei, and the spinal cord, except the anterior horn cells. So although the cranial nerve nuclei are part of the central nervous system, are part of the brain, they are part of the brain, but they are not regarded as central nervous system. The same thing with the anterior horn cells. They are part of the spinal cord. From the structure, we know the anterior horn cells are there in the spinal cord, but it is not regarded as a central nervous system. It is a peripheral nervous system. So the peripheral nervous system, the cranial nerve nuclei, the anterior horn cells, which are part of the brain and spinal cord, but they are regarded as peripheral nervous system. Then you can have any other thing, the nerve roots, the plexuses, the peripheral nerves, the motor end plates, and the muscles. All these are regarded as peripheral nervous system. Why are we discussing that? Because we are going to see what assessments we do that at the end of the day is going to lead into a diagnosis. What are those assessments? Very important. Proprioceptive muscle reflexes. You do your proprioceptive assessment. In central, it increases. So meaning you will have hyperreflexia. In peripheral, it decreases. And therefore you have hyporeflexia. Exteroceptive muscle reflexes. These are your tactile sensations, deep and superficial tactile sensation, vibration sense, and cerebrosis, graphesthesia. All these are exteroceptive muscle reflexes. They decrease in both, depending on the area of the nervous system affected. In the brain, if you have the back of the brain, that's the sensory area, either the somatosensory area or areas that control any of the exteroceptive muscle reflexes, then it will be decreased. But if your injury or disease is affecting the motor area, then it's going to be normal. So I think it's important to understand this. That is not saying in any central or any peripheral, it's going to be decreased. The same thing with the periphery. You have the motor nerve and the sensory nerve. If you have an injury affecting only the motor nerve in the periphery, you are not going to have any exteroceptive muscle reflexes affected. But if it affects the sensory nerve, then you are going to have tactile sensation and others affected. Then the Babinski sign. In central, it's present. In peripheral, it's absent. Muscle atrophy in central is absent or is just mild due to a long disuse. But in peripheral, it's present. The muscle tone, you have hypertonia in central and you have hypotonia in peripheral. And therefore, a clinician that is very clever, if you want to now differentiate between central and peripheral affectation, and remember, I said earlier, the treatment that you give will depend on whether it's central or peripheral. Different interventions, targeting peripheral and central. And therefore, one of the things that you want to do is to make sure that you know if this problem is a central problem or it is a peripheral problem. So these tests are important. You do your proprioception, you do your tactile sensation and other exteroceptive muscle reflexes, you do your Babinski sign, you check for your muscle atrophy, you check for your muscle tone. What they give you as a result will help you to differentiate whether this is a central or peripheral nervous system injury. Now, because of the time, I will not go through the whole of this, but I'm just going to give you a clue. Apart from knowing whether it is central or peripheral, there are categories of central and peripheral. You have the cortex, you have the midbrain, brainstem, like that. It comes down to the spinal cord, to the periphery. Using those assessments that we just looked at, you can be able to know, is this problem of this patient in the cortex, or is it in the brainstem, or is it in the spinal cord, or is it in the periphery? You can be able to know that. The key is this, very important, this, understand how to assess this, how to see the result, then you can use it to make this evaluation or this interpretation. I'll just go through few because of time. Central nervous system. What do you see? Spasticity, weakness. You don't see muscle atrophy when it is central nervous system. It may be pure motor. Now, we are looking at syndromes. So a patient that comes with only one limb affected, some of us will even think that a lower limb problem is a musculoskeletal problem, but it can be a neurological problem. If you have the anterior cerebral artery affected, and the area of the brain, the homunculus, that sends impulses to the lower limb will be affected more than the upper limb area. Most of the presentation of paresis that we see, hemiparesis that we see the upper limb affected more, is because the middle cerebral artery is the one that is blocked or it bursts, because it supplies more of the upper limb area than the lower limb area. But if the anterior cerebral artery is the one affected, it gives rise to a monoparesis. The site is the lower limb. So you'll see the patient having weakness in the lower limb, but the upper limb seems to be all right. How do you know that this is neurological, not musculoskeletal? You do your reflex. If the reflex shows that it is hyperreflexive, then this is a central nervous system problem, not peripheral and not musculoskeletal. If you test for spasticity in the lower limb and you see spasticity, and you can assess spasticity using modified Ashworth scale or Tardieu scale. If you see spasticity, then it is a neurological problem and it is a central nervous system problem. You check for atrophy, there is no atrophy. If the anterior horn cells are affected in the nervous in the spinal cord, it's going to be flaccid. And that is why we said earlier that the anterior horn cell is in the spinal cord, but it is not part of the central nervous system. Because if it is part of the central nervous system, when you do your spasticity test, it will not be flaccid, it will be spastic. But because it is a peripheral nervous system component, it's not going to have spasticity. It is going to come with flaccidity. Central nervous system will have no atrophy, but anterior horn cell affectation will have atrophy. Central nervous system will have increase in tone. Anterior horn cells will have decrease in tone. Another peculiar thing about anterior horn cell affectation is that there will be no sensory deficit. If you do your sensory assessment and you see sensory deficit, it's not coming from affectation of the anterior horn cells. What differentiates anterior horn cell and motor nerve or muscle is that in anterior horn cell, you are going to see fasciculation. But if you have a peripheral motor nerve, you are not going to see fasciculation. If you have the muscle itself affected, you are not going to see fasciculation. So this is one of the striking features of anterior horn cell on one hand and peripheral motor nerve and muscle problem on the other hand, fasciculation. In all the three, you are going to have flaccidity, you are going to have atrophy, you are going to have hypotonia, you are going to have hyporeflexia. You are not going to have sensory deficit. All the three will have the same features. But what differentiates anterior horn cell and those other two is fasciculation. The fasciculation is you see the muscle having this twitch. You see that in the anterior horn cells. You may see that in anterior horn cells, but you will not see that in motor nerve or muscle affectation. This is a little bit trickish, but I don't have the time to explain more. But I hope going through these slides later can give you more information, or possibly Dr. Abba or Dr. Lawan may go into more details on this. Brachial or lumbar plexus. Remember, the plexus, after the roots, you have in the front, anterior is motor, posterior is sensory. As they leave the roots, they come out as motor and sensory. But by the time they come to the plexus, all of them will merge and you will have one trunk, which is the plexus. And that is why you are going to have mixed sensory and motor deficit. So you have decreased tone, you have atrophy, you have decreased reflexes, and you are still seeing both motor and sensory affected. Begin to think of the plexus, either the brachial plexus or the lumbar plexus, depending on whether the presentation is in the upper limb or in the lower limb. So this is one of the things that differentiate plexus and the anterior horn cells. In anterior horn cell, you don't have sensory at all. But in the plexus, you have both motor and sensory. Now, how does brachial as plexus differentiate between central? In central, you can have sensory and motor at the same time. In the plexus, you can have sensory and motor at the same time. But what's the difference between the two? In central, you have increased tone. In plexus, you have decreased tone. Atrophy in plexus, not in central. Decreased reflexes, higher reflexes, like that. So remember, I mentioned the issue of peripheral nerves and muscle and how they differentiate with that of anterior horn cells, and we said that was fasciculation. So when you have hemiparesis, at the cerebrum, you have spastic, facial muscles. If it is at the brainstem, you will still have facial muscles. But if you have an upper cervical spinal cord affectation, what they usually call Brown-Sequard syndrome, you don't have any facial muscle affectation. So whenever you have facial muscle affectation and you have spasticity and you have increased tone, increased reflexes, then think of the cerebrum, think of the brainstem. But when you have no facial affectation, because it's not all cerebral affectation that will have facial. If you don't have, then you will still need to be able to confirm. Is this cerebrum or this upper cervical spinal cord? Then you have para or quadri. Usually it's what we have in hemi, but on both sides. So you can look at that. I've already discussed anterior horn cells, spinal nerve roots. What I want to show with this, remember we talked about exteroceptive reflexes, the tactile sensation. The way we do tactile sensation will not give us good information because each and every part of the body, the skin, is being supplied by a particular nerve. You can see that here. The distribution is that one is trigeminal. So if you go to one and you touch with a cotton with the patient's eyes closed, And you say, can you, okay, when I taught you say yes, and the patient does not say yes, then you know it's the trigeminal nerve as a sensory nerve that is affected. Great auricular nerve, transverse cutaneous nerve, like that. So each area you touch is not representing the whole limb. It's only representing the nerve that supplies that particular area. And therefore, your ability to sit down and look at these pictures and be able to know what area of the skin is supplied by a particular nerve is important. That's number one. Number two, there are affectations from roots. So C1, nerve that comes out from C1, from C2, from C3, from C4. But there are also affectations from the actual nerve after they have left the plexus. Remember, I said at the roots, they are coming as C1, C2, C3. But when they get to the plexus, when they are leaving the plexus, they don't go as roots. They go as individual sensory nerves. And that is why you'll have trigeminal nerve, anterior cutaneous nerve, superior lateral cutaneous nerve, and what have you. And therefore, your assessment can check if the problem is at the root, you use the root. That is why you see L5, L4, L3, and what have you. But on this side, instead of the root, you are seeing the distribution according to the nerve after it has left the trunk. Because the root give rise to the trunk, and the trunk give rise to individual sensory nerves. It's very important for you to understand this because that is what is going to help you with diagnosis. Okay, this patient's problem is at C6. This patient's problem is at the supraclavicular nerve and things like that. So I think I'm going to stop here. For many of you that attended the workshop that we had on systems review and clinical decision-making, clinical reasoning, I took time to explain how you can be able to use biodata, past medical history, family social history, and drug history to be able to suspect that a system such as neurological system is affected. I also took time to explain to you, in fact, I gave examples on neuro because I said I'm in neuro. Said there are categories of conditions. Some of these categories are these ones that I have here. And I said you can be able to use some questions in the history to narrow down from a system such as neurological system to categories of conditions under the system. For example, what is the speed of onset? Is it acute, minutes, or hours? We say it is vascular. Subacute, days or weeks, inflammatory. Chronic, months to years before the signs or the symptoms reach maximum, we say it is degenerative. The same thing with the speed of onset. The interpretation. Sorry, this is the interpretation, what I've already explained. Acute vascular, subacute inflammatory, chronic degenerative. Like that. Pattern of progression. Improving is vascular. Worsening, degenerative. Like that. So in the history, you can be able to ask questions that are going to help you to narrow down to a category under the whole of the neurological system. And then you now do your examination. And the interpretation of the examination will now go back to those syndromes that we just discussed. But finally, you need to have a diagnosis. And that diagnosis should be a physical diagnosis. So I don't have the time to explain this, but I've already explained much of it earlier. And your physical diagnosis, very important that it is not medical diagnosis. You should make a physical diagnosis. If you suspect a medical diagnosis, don't go ahead and make the diagnosis, refer the patient to a physician. And this takes us back to the systems review that we discussed last week and the week before that. I will send you a document on the different types of physical diagnoses that we can make. So what are we treating? Motor system, balance, sensory. So our main diagnosis in physical diagnosis is going to state those things that we are going to treat. But we can say subject to vascular problems or subject to degenerative problems because the way we treat each of those different components will be different. And therefore stating them is very important. So I think with this. Oh, slides. I've already sent the slides on the group. You can check, and if you have not gotten it, then you can ask the admin to resend. Maybe you joined after I send them. So we'll resend them so that those that join later can be able to see them. So I'm sorry, there are many things that I would want to discuss, but I'm going to leave this to Dr. Lawan and Dr. Abba, the issue of neuroplasticity and the issues of motor performance, motor learning, and other things. There are many things, especially this is very important. I believe they are going to touch on it, the different types of long-term memories, so that we'll be able to know what type of treatment we give to patients, depending on the type of injury and where the injury affects. We'll be able to know what type of memory, motor learning that we can be able to use. These are all important. It's there. I've sent them. Oh, sorry. Then the processes of the feedback. Someone was asking about feedback, and I said we are going to come to that. So these are parts of the slide that are talking about the feedback in actual. And then how do you give dosage? I said once, never give a patient intervention without documenting the dosage. So how do you give the dosage? Practice conditions: masked versus distributed, constant versus variable, random versus blocked. These are the ways that we give dosage to the treatment. I'm so sorry that I took you very fast into these things. Usually this kind of trainings should take much more days, but we are compressing them. But it's because of the belief that you are clinicians, you are working in the clinics, you are clinicians, you have gathered a lot of knowledge. What we are doing is just to update, not to really give the raw information. But if there is any feedback that we need to take it easy and give in more details, then we can review this going forward. Thank you so much to everyone. Truly appreciate you. If there are any comments or questions, I will take and then hand over to the next presenter. Okay, so no questions or comments. So Dr. Jibril Samani, if you are there, you or Hafiz, let me hand over to you so that you can introduce the next presenters. Okay, Dr. Fine, go ahead, please, unmute.
Good morning, sir.
Morning, sir.
Thank you very much for the lecture. Please, I just want you to, reiterate that area. I want to get it again. Yes. The middle cerebral artery, the anterior and posterior cerebral artery, vis-a-vis the area of affectation of the body. Can you just take that place again, because the network seemed not to be clear when you were saying that. Thanks.
Okay, thank you. So actually, if you look at the homunculus, that is the motor cortex, is in a form of, I wanted to get the picture. I would have shown you, maybe it would have been better. Let me see if I can quickly get that. Homunculus. Motor. Yes, motor homunculus. If it will work fast, then I can be able, aha, wonderful. So let me just share. So the homunculus, yes. Okay, wonderful. So I'll just quickly share that, and maybe that would be better if I explain it using the picture. Share screen, yes. Okay, I hope you can see this.
Yes, we can.
Yes, wonderful. So if you look at, this is the motor area, and this is the somatosensory cortex. Oh, somatomotor, okay, motor. This is how the brain is. And this area, remember, I was showing this. So in front is where the motor is. And at the back, the blue or purple is where the sensory is. So that homunculus, what it is saying is that in this middle part, what is in there is what is this. This is the area that controls the leg, and this area controls the trunk. This is the area that controls the hand, and this is the area that controls the head, and of course the tongue and other things. So if now the anterior cerebral artery supplies more of this area, while the middle cerebral artery supplies more of this area. And that is why if you have an anterior cerebral artery problem, you are going to have affectation of the lower limb more than the upper limb. There is an overlap. So you hardly have only lower limb or only upper limb. So, but the dominance is that the anterior cerebral artery supplies more of this area, and therefore you are going to have more affectation in the lower limb if the anterior cerebral artery is affected. But if you have middle cerebral artery, which supplies more of this area, then you are going to have more affectation of the upper limb than you will have of the upper limb. Of course, posterior cerebral artery supplies more of the sensory area, and therefore, usually it is even called a sensory stroke because you don't see motor affectation. You just do the tactile sensation is not there. You do proprioception is affected. But when you do any of the motor assessments, you find out that it is all right. And that is why it is called sensory stroke if there is affectation of the posterior cerebral artery that affects more of the sensory area. But the anterior and the middle supplies more of the motor areas, and the anterior supplies more of the area of the lower limb, while the middle supplies more of the area of the upper limb. Yes, so I hope that is clearer now.
Yeah, thanks a lot.
Okay, thank you so much. Dr. Jibrin or Dr. Hafiz, if none of you is here, then maybe Dr. Lawan, if you are there, just unmute, let me hand over to you.
Morning, sir. I am here.
Okay, Hafiz, yes. So please, is Dr. Lawan or
yes,
Dr.
sir.
Abba? Yeah, well, okay, so thank you.
Good. Okay. So please, the slide.
You can share. It's a multiple share. You can share from there.
Okay, I can share. Okay.
Yes.
So I hope it's there. Is the slide there?
It's there. We can see it.
Okay, you can see it. Okay. So good day, my dear colleagues. I'm presenting, the module is assessment and rehabilitation of neurological conditions. So the first speaker, the Professor Rufai, has already given us the detailed explanation about what it entails in the examinations. So now we are going to see what we can match, and then we are going to present some of the typical scenario of the clinical syndromes. So we're going to look at the clinical syndrome in reality, vis-a-vis the neuroplasticity, then the motor behavior, learning performance and movement qualities, and then we look at recovery vis-a-vis with neuroplasticity. Again, we look into the practice condition, that's the prescription, and then the feedback control system. So these are clinical syndromes and encompass a wide range of neurological disorders characterized by a specific pattern of signs and symptoms. And these symptoms, let us, for instance, take a case of a stroke, which is a medical emergency caused by disruption of blood flow to the brain, resulting in what? Hypoxia, which leads to the brain cell damage. More often, they are generally divided two types of strokes. We have the ischemic stroke and then the hemorrhagic type. The ischemic stroke, which is about 80%, which is caused by the blockage in the blood vessels supplying part of the brain, and could be embolic or thrombotic type. And then the hemorrhagic, which leads to the bleeding in the brain due to the rupture of the blood vessels. The stroke syndromes may occur in patients with neurological impairment closely related to the affected area of the brain, because many areas are affected because they are overlap in the affectations. Now, let us, for example, look at, remember the cycle of Willis, which supply the brain circulation. If you look at the anterior cerebral artery, middle cerebral artery, vertebrovascular, posterior cerebral artery, you find out that the anterior cerebral artery supply the superior border of the frontal and the parietal lobes. And patients usually present with contralateral weakness and sensory loss, primarily in the lower extremity, incontinence, aphasia, and apraxia. However, you find out in the wards, if patients are admitted, a patient that has already diagnosed and admitted for stroke management, you find out they are catheterized. Sometimes people thought that catheterization was usually because the patients cannot ambulate, cannot go to the toilet, cannot soil the bed sheet. That's why a catheter is applied. No, rather, no. Sometimes it is neurologically, because of the presentation and the affectation of the brain that present with incontinence, and then catheter was applied. That's one of the issue that gives a problem between the nurses and the doctors sometimes, because sometimes the prolonged catheterization will bring a lot of challenges. Again, look, the middle then there's less involvement in the lower extremity, as has been explained. Also, the vertebrovascular arteries, which supply
Coordinator, Can we reach out to is Dr. Buffer Abba? Dr. Abba, are you with us? Because instead of just staying without doing anything, we can have Dr. Abba come up, or possibly if there are any interactions that you want us to have, question or answer, or if there is any section of what I've presented or I showed briefly through the slides, or if we prefer to wait for him, just give feedback. Let's know what's the best to do.
Can we have the next presenter if he's available?
That's what I'm asking. I can't, possibly because he knows he's coming after the break. He may not have joined. Please, Hafiz, can you reach out to Dr. Abba, find out if he's going to join us soon.
Or if we can go on mini break just for him to resolve the network issue.
Yes, that's another good one. So maybe let's take 10 minutes break. Is that all right? Do we take 10 minutes break and come back by 11:55? Is that okay?
That would be okay. If that will help him to resolve the network issue, that would be okay.
Yeah, no, even if he doesn't resolve it, by the time we come back, we'll do something. I have a lot here, and Dr. Abba can also join us. So I don't think we will really be idle doing nothing. So, but let's just take 10 minutes break. We'll come back by 11:55.
All right.
Okay, Dr. Long, you are welcome back. Dr. Long, can you hear us? You will need to unmute so that we'll communicate. Let's know if you are back. We went on a short break, 10 minutes. We are back and we are waiting for you to take over. I think he's having challenge with network. Dr. Abba, are you with us? Muhammad Aliyu Abba. Okay, Long is back. Please just speak so that we'll know if you are with us.
Okay.
Okay, Marlon, you're back, right? I can hear you now. Dr. Long.
Okay, now what?
Oh, okay, so everyone is waiting. Just want to be sure that you are with us.
Sir, can you hear me?
Yes, we can hear you.
Sir, can you hear me?
I can hear you very well now.
Okay, okay, that's very good, sir.
Yes, go ahead.
Sir, the rehabilitation of neurological condition, the module was assessment and rehabilitation of neurological conditions. So the assessment part has been dealt by the register of MRTBD. Then now we are going to look at the syndromes clinically. We take few examples of them. So yes, we are going to look at the neuroplasticity, then motor behavior, learning, recovery and compensation, practice condition and feedback control system. Then, how do you understand the brain attack? Stroke is a medical emergency caused by disruption of blood flow to the brain, resulting in brain cell damage. We have ischemic. Generally, there are two types of insult to the brain. that of vascular origin, ischemic stroke, and hemorrhagic stroke. The ischemic stroke can be thrombotic or by embolus, and it's more of about 80 to 85% of the stroke we see in our clinics. The hemorrhagic stroke, which is caused by bleeding in the brain due to a ruptured vessel. So the affectation of these blood vessels at different levels in the brain present with so many different clinical syndromes in stroke patients. For instance, if this affects one of the circulation, the cycle of Willis that supply the brain, let us take, for example, anterior cerebral artery supply the superior border of the frontal and parietal lobes. Most likely, the patient present with contralateral weakness and sensory loss, primarily in the lower extremity, has been explained by the previous presenter. However, also the patient present with incontinence, aphasia, and apraxia. However, the incontinence aspect has been a bone of contention between the nurses and the physician, whether the patient should be catheterized or not, because they are thinking that catheterizing the patient just because he cannot go to the toilet because of inability to move, rather than because of the stroke presentation. However, also, if you look at the middle cerebral artery, supply the surface of the cerebral hemisphere and the deep frontal parietal lobes, which patient present with contralateral sensory loss and weakness in the face and upper extremity, less in the lower extremity. So from there, patient presentation, you will understand which symptoms patient is presenting, which symptom the patient is coming with, so that you could be able to come with a physical diagnosis. You know you are handling a patient that have more problem with the lower extremity or have problem with the lower extremity. Also, the basilar arteries supply the brainstem and the cerebellum, which is a small brain. You do observe there's involvement of cranial nerves which affect vision, swallowing reflexes, speech, because affect muscle of the tongue, and then the pace. And also patient present with vertigo, ataxia, equilibrium disturbances, headache, and dizziness. However, if there is complete blockage of this basilar artery, the patient presents with a particular syndrome called lock-in syndrome, where he lost all the movement except the eyes movement. There's no particular movement in the face, in the extremity, and also can only move his eye and cannot communicate. This is commonly called lock-in syndrome. Also, in the posterior cerebral artery branch that supply the occipital and temporal lobes, thalamus and upper brainstem, patient present with contralateral sensory loss, memory deficit, and then visual and agnosia and cortical blindness. So you find out the patient everything he could see, but because it affects the occipital cortex, where vision is being interpreted by the brain. Also, another common syndrome that we see in stroke is lacunar syndrome. It affects part of the brain, internal capsule, falls, thalamus, basal ganglia. So the dead tissue in the deep part of the brain can be removed by the neurosurgeon and will leave a cystic cavity. So this is why it's called lacunar syndrome. For such patient that had particular intervention, they come off with contralateral weaknesses and sensory loss, ataxia, and dysarthria. Other stroke syndrome that we could see in our clinic is parietal lobe stroke syndrome, which is characterized with inattention or neglect of the involved side of the body. Mostly they come with what we would call spatial neglect. They take themselves or they turn their head away to the affected side. Then the impaired perception of vertical, visual, spatial, and topographic relationship, which is very difficult to handle. They have persistent involuntary movement or motor response. And the clinical implication is that those kind of patients with this particular syndrome, they are difficult to manage in the clinic because you find out you cannot direct them to new ideas or new activities. So their learning is severely affected. And some of the manifestations sometimes varies depending on the hemisphere that is affected. Another common syndrome that you could see in clinic is thalamic pain syndrome. Stroke patient will come with severe pain secondary to any stroke. Could it be hemorrhagic or ischemic? There's most likely the affectation of the thalamus and posterior limb of the internal capsule or parietal lobe. The patient experiences intolerable burning pain and sensory perseveration. Sensation persists long after the tumors has been removed. So any part of treatment, whatever you do, you are inflicting pain to that kind of particular patient. So you have to refer the patient for multidisciplinary approach where you'll be placed on some high level of analgesic that will control the level of the pain and use your modality available, and then you continue to use your rehabilitation modalities. Another common syndrome that we see is pusher syndrome, seen in patients with stroke in the right or left posterolateral thalamus. If there's affectation of posterolateral thalamus, and the prevalence is approximately 10 to 16%. Patients actively push and lean toward their hemiplegic side and at increased risk of balance. They have poor balance and then could lead to. And you find out even at sitting, they have poor balance. If what we talk less of dynamic balance. The common clinical presentation you see in this patient, they have cervical rotation and lateral flexion to the affected side. They have visual deficit and truncal asymmetries. They always put their weight to the unaffected side during sitting activities in any transfer that you can think of. And they are very, very resistant to any maneuver or manipulations you wanted to achieve, like when you want to give them PNF or when you wanted to retrain functions. So you find out any activities, you find out they are very difficult because they have mismatch between perception of vertical and body orientation. So therefore, in their treatment, you met a lot of resistance, and however, we use a lot of multidisciplinary approach to see what we can do with them. So understanding these syndromes is essential for comprehensive stroke management and rehabilitation. The same thing, now we have seen an acute injury to the central nervous system. Now we are looking at another journey through neurodegeneration aspect, the disease that affect the central nervous system. Parkinson's disease is a progressive neurodegenerative disorder affecting movement due to what? To the loss of dopamine producing brain cells in the basal ganglia, specifically substantia nigra, because it's a neurotransmitter that works through the striatum to modulate movement activities, to make choice for an individual to affect any motor movement. So patient present with slowed movement, bradykinesia, postural instability, tremors at first, and other psychosocial problems. The management generally is physiotherapy, occupational therapy, but initially there's some aspect of their conditions that we don't usually succeed until when we combine it truly with medication. They have to be on drugs to supply that, and then we already make an effort to improve their quality of life. Another deciphering things that we see at neurological condition is the memory loss and cognitive decline, which is seen in dementia, characterized by a decline in cognitive function, severe enough to interfere with daily activities. Such primarily is described as Alzheimer's disease. And then the common one that is silently seen in our clinics, but we don't usually pick them early, is vascular dementia. Most of the stroke patients that have small vessel issues and what have you, they likely come with vascular dementia. Sometimes you find out their motor aspect is very good. They are doing very well. But you find them, they present a lot with decreased cognition. Then the last is Guillain-Barré syndrome, which is a rare autoimmune disorder where the immune system attacks the peripheral nerves, leading to muscle weakness and paralysis. So, is Guillain-Barré syndrome a central nervous system issue or peripheral nervous system issue? So, if you look, the peripheral nerves, it's at the myelin sheath that is responsible for smooth transportation or sending impulse by the nerves is being affected, and usually even the nerves itself. And at motor level, you find out there's classical muscle weakness. You see paralysis. So in the severe form, you can even affect upper respiratory tract. It can affect other part of the system apart from the musculoskeletal system. So the weakness come off with sensory effect. They present with tingling sensation, which will start from the legs, from the lower limbs, and spread to the upper body. You find out there's what loss of reflexes. So it's typically, it is atypical or atypical peripheral nerve injury, insult, or central nervous system issues. You find out this the affectation features of the lower nervous system. Then the commonest when you look at these CNS disorders, you find out they have similar symptoms in all of them. Or some come off later or later, early. Some present later. For instance, let us look at the functions, coordination. You find in stroke, in Parkinson's disease, in dementia, okay, multiple sclerosis. Though I didn't say much about multiple sclerosis, it's not very common here, but it's one of the neurological conditions that you encounter in any literature that talks about central nervous system. So it's the system of the immune system of the body that attack the peripheral, the nervous system, including central nervous system. Patient present with so many similar syndromes of presentation that affect ability to move, sensory, motor, fine, sensory, a lot of, and it has remitting. It can relapse and it can improve. And some can have primary onset and continue to produce weakness. And a lot of it disturbs activity of daily living, and the patient will have poor quality of life. So these symptoms that generally that is common to all these CNS disorders that form this neurological syndrome are many. Let us take function. You find out they have poor coordination in stroke, in Parkinson's disease, in dementia, in multiple sclerosis. You find out agility, stamina, which is fitness level. They have low fitness level, muscle strength, speed, that is walking, sensation, and what have you. You also look, they have neuropsychological functions. They have poor attention, orientation, in stroke, in Parkinson's disease, but in dementia and multiple sclerosis, usually they don't have problem with orientation. But in multiple sclerosis, they have problem of perception. They have CBA, Parkinson's disease have issue of memory. Multiple sclerosis, they have issue of memory. Dementia too has an issue of memory. Language, the same problem. Executive functions, how to carry activities independently. Information processing, and also activities that involve self-care, transfer, walking. Then welcome to social participation. They come off with pain, fatigue, depression. So these are the commonality of various symptoms that we see in all these patients. But you find out the assessment sometimes are similar, and then the intervention depend on the assessment and the kind of condition and the region that is affected, or the part of the central nervous system that has been affected. So we go further to look at the recovery. What is happening between plus after this injury with all this presentation and there's our intervention? What are the likely explanation scientifically that shows what's the end point of our assessment intervention of these clinical syndromes, neurological clinical syndromes. So let us look at the plasticity. Let us concentrate on the word plasticity. What quality do you think this word is conveying about the brain? If the word plasticity didn't exist, which word do you think psychologists could use to replace it? Is it remodeling, brain remodeling? What do you think? So the term has contain diverse processes as from learning, memory, and the execution of normal activities. Let us look at dendritic proning and axonal spotting in response to injury. When there's an injury, so the part of the nerves, the dendritic region where I have synaptic connection between one nerve to other, or the axon, there's spotting or there is proning. Some dies, some improve, some grow. So these three explain the fiction, what actually happening when plasticity or recovery is taking place through plasticity. So what is this neural plasticity that we are talking about? This, if you look at it generally, it's just neural repair. It has been in the past, but now modern technology in neuroimaging and transitional neural research has added a lot of idea and opening toward understanding this neural plasticity. You find out it enhances axonal regeneration, that transplantation of variety of tissue and cells to replace lost neurons, and even the use of prosthetic neuronal circuit to bridge part of the nervous system that had become functionally separated by what? Injury or disease. You could also see during infancy, the brain undergoes rapid synaptic growth, which has many connections as in adulthood. But through this cognitive pruning, rarely used connections are eliminated. The connections that are used that are important for our survival evolutionarily have been developed. And some are reinforced, highlighting the brain's ongoing evolution from early growth to refinement and adulthood, and through the various experience, we learn. This is why it is believed now, even after Pillar 2, if you are managing the neurological condition, a typical case of a stroke, after 3 to 6, the most vital period of recovery. But still, now, modern research has shown that after 2 to 3 years, you can still make progress because of existing demonstration of that plasticity of the brain is ongoing process through life. This describes the brain tendency to change and adapt both functionally and physically as a result of what? Experience or new learning. What are the positive outcomes of this neuroplasticity? There's new skill, better cognition, more efficient communication between sensory and motor pathway, improved function of the aging brain, slowing down pathological processes, promoting recovery of sensory loss, and lead to what? Functional recovery. After physical injury or trauma like infection or stroke, unaffected brain region can sometimes adapt or compensate for damaged area, showcasing neural plasticity. If you look at this, the arterial supply of the anterior cerebral artery and medial cerebral artery, you see there's overlap. Even the motor and premotor and motor cortex, they are still overlap of functions. So sometimes it is very, very difficult to delineate, between one point of a brain to another point. So this brings the concept of compensation, where some part of the brain could be compensated. Neuroscientists propose that this recovery can occur rapidly for trauma, but may be slow and take many months. What happens in the brain during recovery? It is the brain itself, it's rare. It will organize itself by forming new neural connections. axonal sprouting, reformation of new blood cells to nourish the other part of the brain to fix similar functions, recruitment of homologous similar areas on the opposite hemisphere do the specific task from left to right hemisphere. Also, activity-induced neuroplasticity that enhance. If you look at this part of the brain, you look at this the primary motor cortex area. That's an insult into the brain that represented what the hand functions. This before, if you look at the other two pictures, you find out the first one, that is what reorganization, like cortical mouth. It has enlarged. The other one, there's no intervention, there's no rehabilitation, no activity that induce neuroplasticity. So the place is remain like that. But the other part, the lower part, if you look at it, there's a lot of activities that enhance the organization of the cortical mouth, which produce result or improvement in symptoms, in functional activities. So in summary, there's plasticity at the cortex level. There's plasticity at the motor system level. There's plasticity at the somatosensory system. So if you use it or lose it. You stimulate the somatosensory system or you lose it. This thing take you to the next slide is compensatory strategies. Recovery and compensations happen at the same time or simultaneously with intervention. It is the use of alternate neural pathway or strategies to perform tasks or the brain complex movement, choose another strategies to select another function. There's so many different. So we're going to discuss the theories in the next few slides to perform such tasks that is being deficient after injury. Another example for intervention is task modification, adapting tasks to match the individual abilities. That's what mostly we do in a clinic to compensate for a particular loss. Or environmental modification, use certain aids or assistive device or technology now in general to enhance independence. Sometimes we use cognitive strategies, utilizing memory and or external cues to compensate for cognitive deficit, especially in patients with multiple sclerosis or in with dementia, to live and improve their quality of life. Now, we are moving to motor behavior, learning, recovery, and compensations. If you look at there's basic principles which you should look at it. You see, presenting a treatment situation context to support the patient's ability to learn motor tasks. That's about this emotion. These principles are emotion, motivation, meaningful goal for transfer and retention. Because whatever you taught or the patient learned must be able to transfer it, must be retain it, that afterward can use it for survival strategy, which is immediate environment. Also, repetition and variability in practice. Stages of motor learning, because the learning process always takes stages from one stage to another. Then shaping, try to put the activities from simple tasks to higher tasks, increasing the difficulty, which will enhance learning and then improve what? Activity of daily living and generally improve quality of life, activity and participation in the community. Practice conditions. At what level? At home, in the clinic, in the gym. And look at the factors, intrinsic and extrinsic factors that will give attention, feedback, active participation, rhythmic cueing, cognition, and then task-oriented practice. Now, what is motor control? Ability for me to run, for you to walk, to swim. What is the big picture? First is the motor behavior, the motor control, motor learning, and then finally motor development. That's what happens in developmental milestone of us adults from our infancy to this level of life. What are the motor behavior? An area of study stressing primarily the principle of human skill movement generated at a behavioral level of analysis, action, perception, cognition. So you have to have act, you have to perceive, you have to recognize the movement, and then you have to interact, then you make the tasks accomplished in an environment. That is motor behavior. What is motor control? An area of study dealing with understanding the neural, physiological, behavioral aspect of movement. From what it is very clear from the first presentations how these processes have been recognized and happen stage after stage. Then two main aspects of motor control: stabilizing the body in space, postural and balance control, then moving the body in space, which has been explained in the earlier presentation. Now, motor learning, the study and understanding of the acquisition or modification of movement. This definition can be used for both the acquisition and the reacquisition of movement. That means learning and relearning after central nervous system lesion. Motor learning emerges from a confluence of perception, cognition, action, which is, if you look, it is intertwined with motor behavior. Motor learning can be described as a search for a task solution that emerges from an interaction of individual within the task and environment. So that is just the concept. It's a relatively permanent change, which is distinguished from performance. Performance, you are just doing it. But when you're doing it, you'll be able to what? To be part of you. So it's become part of change. Or it's a temporary change of motor behavior that we've seen earlier in the earlier slide. This led to the notion that learning could not be evaluated during what practice, but rather during specific retention and transfer. So the transfer and retention are part of the principles of motor learning. So now let us quickly look at how do we apply this principle of motor learning and control to rehabilitation through a comprehensive journey using a simple case study that we can imagine. How do we integrate key concept of motor learning and control into a left hemiparesis rehabilitation for individual with neurological condition, focusing on the case of Joy, a 38-year-old female with left upper extremity paresis. The importance is attached to how do we understand this motor control through this very typical principle. Why we should study this motor control? Improving movement capability following injury to guide clinical intervention. This is one of the major reasons. So we have to go back to start translational research at laboratory level that we can translate it at human level to improve motor performance, and generating and building theories. Because without this theory, some of our intervention could not stand. We have to create theories, build frameworks, models to be able to explain what we are trying to say. What is a theory? Because I'm going to discuss theory in the next few slides. A theory of motor control is a group of abstract ideas about the nature and cause of movement. Remember, the first presenter was saying there was about 19 movements that are stored in the basal ganglia. So it is the shoulder or the arm or the hand that will choose which one is the brain will choose. You see, so it's very abstract, but we have to have a model that will quickly paint a picture of what exactly these theories are saying. A model is a representation of something, usually a simplified version of the real things. Now, if you look from infancy to older adult, individuals adapt motor skill to changing abilities and context day by day, month by month, year by year, until all those movement has been adapted to us. It's become an automatic aspect of our activities or our daily living. But then when we have challenges, neurological condition require learning. When we have challenges, that means neurological insult. So we need to learn those motor skills because they were altered. So we have to develop rehabilitation protocols that will make sure we'll be able to regain those functions that we lost after it has been part of us, that we are doing it automatically without us knowing, because brain is processing it in a milli or nanoseconds. Now, let's look at how this man and this young woman were dancing, moving their hands, their legs, automatically without conscious of, okay, let me raise my hand or raise my leg. And then they have an insult to the brain. They now can no longer sit, stand, or walk. So eventually, in the early part of development of this concept, the common theory that was used is reflex theory, because they assume that we are born with some brain stem and spinal cord primitive reflexes. Those reflexes, do become extinct one while we are developing through the developmental process, but it's not that they're absent completely. They become part of the voluntary movement. So this is why, if you look at all those old books in the 60s, you find out whatever they are trying to explain in this motor control theory, they are using what? Reflex theory. But with the advancement of research and development in imaging, in neurology, so all those theory has been gone. Because when you have an insult to the brain, so those primitive reflexes now comes back again and dominates. So this is why you have to see those pattern management. So that was the theory that was used in 1900 to explain the motor control theory. But with those advancements, now a system model was developed year after year, a framework which serves as a framework for movement. The system view movement results from the interaction of multiple systems. If you look at the brain, from the cortex, pre-cortex, from the pons to the brainstem to the cerebellum, you see those tracts, ascending, descending tract, spinothalamic, trical, tectonal stack. So multiple of all those things play a serious role, from basal ganglia to pons to wherever to some cortex, pyramidical stack, ascending tract. So all those movements result from the interaction of multiple systems. That's what gives flexibility. What's the meaning of the flexibility here is consistency. You can carry this movement today, tomorrow you will carry it again, or in the next hour you carry it. If there's no that a system that is coordinating it, you cannot be able to do it, more or less, to be adapted to be part of you. So now let's just consider this Joy. She wanted to dress her upper part of the body. Know that it's internal and external factors to influence her movement strategy. She wanted to dress, she wanted to wear her shirt. What are the factors do things using this model, this framework, system model that will help her to know, so first you have to look at the external factors. Know that it's internal factors and external factors. The internal factors is what we get from our physical assessment. You've muscle strength. Is it the synergy? Is it having shoulder pain, post-stroke shoulder pain? Is it have the strength? Is there's the movement? Or there's loss of movement? So these are the internal movement. The external factors, you have to start, okay, the shirt, is the neck very wide? Is where the hands comes out is very large enough? Or she is sitting on a bed? Is the bed giving her a lot of support for her with her legs on the pillow to raise her hand, or to raise the affected hand, the hemiplegic arm, or the left arm? So these are the external factors, so that you look at. That's what will bring compensation and other strategies. So for her to complete the task of bracing upper body, all available systems must work together to produce what? Single strategy. That's what Prof was trying to tell us about the basal ganglia, how that movement is being coordinated. There are so many movements. Impulse is coming to the shoulder, it's coming to the arm, it's coming to the hand. So, but here we have a simple, model. So all those systems that you can think of, you can remember, must work together to produce what? A single strategy. Otherwise, Joy could not use her hands to wear her shirts. Now, we just mention of degree of freedom problem. So this degree of freedom problem is not at a physical level of the patient. It's at central nervous system level. That's what is happening at that basal ganglia, premotor and premotor areas. Premotor, area 6, prefrontal cortex. The nervous system feels the degree of freedom with vast movement options available for any action. So the movement are plenty. But the solution is the brain through the system will minimize the degree of freedom to allow for smoother, more efficient movement. This is why joy in initial movement may involve muscle core contraction to stabilize against undesired movement. She will not stabilize her shoulder, maybe so core contraction, so that you could be able to what? To reach the shed or to bottom or to don the sheds. Because if there's no that reductions, minimizing that degree of freedom, choosing from multiple options and the central nervous system for a particular movement to take place, then you could not be able to minimize that more. So therefore, there is a redundancy. So you have to overcome that redundancy. So you have to select, the brain have to select that particular functional movement. That what will lead us to the. So those during the early stage of learning how to dress her upper body, joint may produce very simple movement and limit the amount of joint motion by holding some joint stiffly via muscle contraction. So she will attempt, small attempts to move at the shoulder, then move at the arm, and then at the hands. This action decreases the degree of freedom, allowing for greater success. What I mean, the impulses from the central nervous system will be coming bit by bit at a different location to provide a particular pattern or segment so that she could accomplish that task. As the task is learned, joint muscle core activation may decrease so that there will be more and finer movement. So there's fluidity as her skill improves. She will exhibit greater success, reflecting the ability of the central nervous system to use what? Multiple motor resources to accomplish a particular selective task. So, what are the theories that comes out that are very dominant in explaining this using using a particular framework? There's central control theories. Focus on neural storage of motor plans. It means that all this multiple of information that the brain had, whether it's it's explained by motor program theory that there is a storage that keeps all those movement math plan in the brain. Novelty, what of new works for? What is motor equivalence? Similar work. So the challenge, you have to address these two issues. How much, if you say if you can think of any activities that you do that the brain is storing, it has to have a storage. Otherwise, you cannot carry out. So if you want to carry a new activities, then the brain must have that map of that new activity. And then you can find out some activities of movement that are similar, they are equivalents. So how do you address this? So central control theories in its work scheme argue that motor programs do not have to be specified for every action. They are generalized programs that contain certain rules. What it means, just like a programming or a computer, you can set a rules, a guidelines that any program can fall into it. So the brain also, using this model, specify every generalized program to contain particular rules for a large class of a similar action. So the actions are similar. Those motor equivalencies, so they are similar. They are put together so that even if you are doing a new thing, that's a similar work. So that's how to explain this. So to minimize this, the storage needs account for novelty and new action in any version of other action groups.
Ma, I'll be reminding you of Ankara now.
So the next theory from the two dominant theories, dynamical system theory, may emerge from interaction with the environment, emphasizing adaptation and flexibility. In the dynamical system theory, physical movement is constrained by what? Characteristics of the individual environment and task. Which is very, very important for physiotherapy, because whatever you are doing, what patients you have to look at, whatever you are doing, you have to look at the environment of the patient. Are you seeing him in the clinic? Are you seeing him in the gym, in his house, in a community clinic? So physical environment is very, very important, because let's just look at a Joy. Is Joy the house he is? Is this a floor? Is he sitting on a bed? Is he sitting on a mattress? Because all those come into play for her to carry out this movement that we want her to teach her. So at what level do we intervene? This is an attractive idea when working with patients, as changes in their body structure, let's assume that hemiparesis, will represent a shift in the subsystem, allowing for a new adaptive motor pattern to emerge. This explains the compensatory mechanism that is coming upstairs, actually from central nervous system. So as the system change, so the subsystem will also change to adapt to the pattern. That's what dynamical system theory. So these are the major two theories that are used to explain a model that could practically show us how to handle this patient. So by implication, both theories offer insight into how movement patterns are selected and executed in influencing rehabilitation strategies. So we have to bear in mind that with this insight, we'll use this pattern to select and execute influencer rehabilitation strategies. Now, we have mentioned the theories, the model, the strategies. Now we are coming practically. How does this patient will acquire this skill? If the patient acquire this skill, how the patient can achieve consistency, which is repeatability of performance, flexibility. How can he transfer this skill from this skill to another skill? Efficiency. How this patient can have stamina or fitness or have cardiovascular and musculoskeletal system to participate in our structured program or intervention. Can John maintain a sustained sitting position without becoming exhausted? Or does an extended period of sitting limit her activity for the rest of the day? So you find out we are giving an intervention or strategy or protocol to a patient, where the patient goes back home could not do anything because we couldn't look at the efficiency. That means, does he have the stamina, the volume of the treatment or the protocol or the repetition or the prescription is too much for the patient to survive it, or will be for other activities in the day. So we have to be mindful of these three things in acquiring this skill through these models. But by the time patients started to perform, that indicates skill acquisition, which varies in level within any motor task or motor activities. But you see this skill acquisition, it has stages. It has the early stages. You found that maybe Joy in her first movement is, you look, it is poorly controlled because he was focused on basic movement pattern, maybe flexion extension, wanted to extend or carry the hand up and down, and then trying to understand the environment. Then the later stage, you find out the movement has become refined, very efficient. That means she has transmigrated from what to do to how to do. Initially, at early stage, is what to do. The patient looking at the environment with the inherent limitation. That means internal factors, how to carry the movement. By the time he has just 1 or 2 or 3 movement, and then it become part of her, then she has now moved how to do the movement. By the time she's at the level of how to do the movement, so the movement quality, quantity will be improved. So eventually, a learning has taken place. However, you have to consider learning is not linear. There's period of what improvement. Patient will be making progress, and then there's some patient can reach a plateau where no more progress could be observed apparently. Or the patient can regress. But that does not mean patient is not making progress, because learning is non-linear. So the process of learning, there's explicit and implicit learning processes. Explicit learning process focus on goal attainment and conscious adoption of movement pattern. At the beginning, at the early stage, the patient mindset was how to achieve that particular movement. But gradually, after she's attained some level of skill, then implicit learning come in. Patient unconsciously will be managing movement, refining the motor control strategies over and over, again and again. Before you know, she will integrate both the explicit learning and the implicit learning processes to produce what? a dominance, good outcome of motor skill. So both the explicit learning and implicit learning, they coexist throughout the learning process, with explicit dominance in early stage of just like what to do, on how to do, or what to do, and then in the later stage, which is what to do. That's the implicit stage. So integrating motor learning into rehabilitation. In summary, integrating principle of motor learning and control is crucial for effective upper extremity rehabilitation, as we have seen in the case of Joy. However, the consideration is that skill acquisition stages have different learning process and then adapting interventions accordingly. So when the patient is at this level, you should be able to understand at what level is he and how much intervention are you giving. And also, this will lead to the progress. Now, how do you classify motor skill? Understanding skill types, that's what we call, we're now talking about the skill. We have fine and gross motor skill. We know the fine motor skills affect what? The small muscle group, while the gross motor skill involves large muscle. So Joy may use both small and large muscles for upper extremity, stabilizing the trunk while reaching in tandem. Also, there's discrete and biscontinuous movement. Movement with defined start and end point. So I call them discrete movement. There's movement that are rhythmic, that are continuous. For instance, if you want to on light, by the time you on the light, movement has finished. If you want to stand, by the time you stood, the movement has finished. It has beginning and has end. But if I'm walking, it has no starting point and ending point, but you are walking. If you're like you're swimming, you are driving. That leads us to what we call open and closed skill. Even in orthopedics, they are using this often closed kinematics exercise and closed kinematics, considering the environmental stability where closed skill remain constant. What I mean, the environment constant. If you are seeing a patient at the gym or in the clinic, the environment still remain constant and often to skill and adapt to changes. So how do you promote this skill after it has been acquired? So you have to structure your session, your treatment session. That's, you have to know how to prescribe the treatment. Amount of practice. First, you look into the amount of practice. More practice leads to improved capabilities. Observe in developmental milestone and rehabilitation paradigm like conscious-induced movement therapy, where you practice, more practice lead to what? More performance, then more skills. So this is one of the way that you can structure your session. Let us look at Joy or left hand control. May decide to perform 30 trial of inserting a key into a lock and turning it at once. 30 times. Or inserting a lock and key and distributed into 5 trials. Now maybe say you do 5 trials now in 5 minutes, or do 5 trials in 10 minutes. So this is demonstrating that we are giving her what? He can do it as a block, that we'll see in the previous slide, as a block or as part. So the whole, deciding whether to practice a task in entirety or break it into segment, depend on task analysis and interdependence of segment. There are some tasks, like Joy maybe wanted to wear her shirt, or her shirt, don her shirt. You can maybe ask her to raise her shoulder off. Then you can ask her to extend elbow, or maybe reaching a cuff. Take example, hand reaching grabs. You can ask him to take the hand, move to the cuff, then now grabs. So you can put it into segment until the patient can learn. So it can be a fat, but the intervention here, one have to be very careful, so that you cannot put the program into segments where the patient cannot even learn. Instead of enhancing learning, we now also cause regression. Then constant and variable practice. Choosing between repetitive practice, just like Joy decide to perform 30 trials of inserting a key into a lock and turning at once, 30 times. That's constant, versus brain task condition. How can you brain it? You can have different key and locks. So she can turn into different, maybe let's say A, B, C. We have 3 keys and lock with different shapes. So even the position of hand would be different. So instead of her performing 30 trials, inserting a key into a lock and turning it at once, or you now have different 3 keys, and then in different position, you position the key, the lock into different position. You now ask Joy to be inserting the key and turning it into the lock. So you have given variable practice. What the researcher said, in fact, skill retention is higher in what? In a variable practice. So, amount of practice, finding out how do you find the optimal balance. The principle increasing practice time enhance skill improvement and capabilities. While you even see, even in learning, we understood that sometimes it's just not you to know the book, but sometimes to master the book. But how do you master the book? How do you attain the mastery level? Is through what? Practice, enhancing, increasing practice time. That will increase skill and improvement and capability. So it's the same thing. This principle is applied to the patient. Why? If you observe children reaching abilities, develop over years, you remember 2-3 months, just at sitting rolling, 6 months, nine, start standing and eventually walking. So for that child to do that, it has taken a stage, many attempts before it reached to a certain level. So if you look at even graphs, reaching abilities alone, it takes years through repeated attempts and learning from trial and error. So in the same, that's the advantage of increasing practice time, which enhances skills. So that will help us to find what? Optimal balance. So this is why you find out in CIMT demonstrates that intense structured practice lead to functional what? Improvement and changes in the brain structure supporting what? Neuroplasticity to take place. So how do you measure motor learning? How do you analyze performance? Motor learning confidence is 3. You have to acquisition, you have to acquire the skill. If you have acquired the skill, retention, that means after practicing or after a while, or 2 or 3 days, you could be able to carry out the same skill. Then it has been retentive, it has been retained. Then the transfer of skills, ability to use that similar skill, similar activities. So that's essential for measuring motor learning. That will show that really you have learned. Otherwise, if you cannot transfer, if you cannot retain, after some hours you did some exercise, some activities, especially task-oriented practice, and the patient could not do it a month also. That's why I feel very angry when I see a patient that came early. You're just trying to teach functional activities. You start from lying to sitting to standing. Then I've realized now you have now got to the level that patient is trying to ambulate, or you are trying to ambulate a patient, but then patient cannot what? Sit from lying. So all functional skill at a particular level, there should be a retention and there should be ability of transfer. So now let's look all by part practice that we have. Considering task complexity, some tasks at the beginning is very complex. And when you look all those patients, when we look at these syndromes, we find out all of them, one way or the other, they have some level of cognitive impairment. So sometimes it's better you give them a continuous task. Practice entire movement is beneficial due to interdependence of some segment because of this theory. Because as they continue to practice that movement, they now find themselves into what? Serial movement. So after that serial movement is formed by those continuous tasks. So if you have different continuous movement, will invariably form a serial movement. So this will help you to practice as a whole or in part. Considering temporal relationship and movement dynamics of the patient. Some have special postural problem, equilibrium problem, what have you. So it's looked sometimes to do a complex activity. So you chef. That's why chefing comes in again. You start by fat, then you chef it to the level that you become, or you give a whole practice. Then the constant and variable practice, which you have explained. The constant practice repeating the same task improve performance, but may limit skill retention and transfer. That's the problem of constant practice. But the variable practice introducing variation, challenge, adaptation. All those systems, the complex system in the brain, the interaction of multiple systems will be enhanced using variable practice because you are introducing variation. You are changing the position of the lock and turning it. You are changing the type of the lock, not just giving one lock, doing 30 tries. At the same time, the practice schedule, which gives the actual prescription stage, blocked, random, and serial schedules influence contextual interference and learning outcomes. What I mean when there is contextual interference, when there is a lot of variability, so learning and skill acquisition is faster with higher degree of what retention and ability to transfer the activities. How do you maximize learning potential? Still, we are talking about prescription. Block practice performing consecutive trials of the same task before moving on minimize interference but potentially hindering learning. Yes, but that does not mean you cannot do it. You categorize your patient based on their cognition. So this is why assessment of mental skills is very, very important. Assessment of cognition, even if you cannot use any scale, but you could be able to use some, some words, some 3 words. There are simpler ways of, doing mental screening. Random practice, introducing variability, challenges, and adaptation, promote better skill retention and transfer, which will give patients that have less cognitive impairment. Then the major consideration is choosing the appropriate practice schedule depend on task complexity, learner characteristics, and learning goal. For prescription, whether to use block practice, random practice, the consideration is you have to look at the patient. First, that's learner characteristics, inherent and external characteristics and internal characteristics, ability, strengths, stamina, cognition, and what have you. Then the complexity of the activities, removing a shirt through the neck, through the arm, with left hemiparesis. How do you break it into similar? Is this going to do it while standing or sitting and what have you? So the complexity of tasks matters a lot. These are considerations. So there's patient that it's better to use block practice. There's level to use block practice. There's level to use random practice. Also, the goals. What do you want to achieve? So these are the basic construction in prescribing using that. So enhancing motor learning through practice. The summary is structuring practice session effectively and crucial for promoting motor learning and skill acquisition. Prescription. Key factors, consider the amount, then the type, schedule of practice, and to ensure long-term learning and skill retention. To ensure long-term learning and skill retention. What are the future directions? Both are research and clinical experimentation are needed to optimize practices, strategies for individuals with neurological impairment. This now takes us to the next level, the role of mental practice, enhancing performance through cognitive rehearsal. Because all what we are doing in terms of practices, condition of practices, it all revolves our cognition. So we realize that this mental practice is very, very important. Prescription of mental practice involves cognitive rehearsal, imagining what the patient is doing, what are the benefits. Such improvement in motor skill with mental practice alone so at the same time, you are giving him, imagine you are carrying this cup, you can grab this cup, you can don your shirt, you can fasten your buttons. What is the size of how does the size of your buttons affect you putting your buttons on your shirts? So the role of mental practice is very, very important to be inculcated during such practice. So neural process during mental practice closely resemble those required for physical performance at the central nervous system. What I'm asking Joy should do what visualize herself going through the steps of dressing her purpose. Concentrating on the movement required and feeling how their imagined body is moving. So and now you add your prescription. So mental practice, what is the application? Mental practice involves visualizing movement and concentrating on the imagined body's sensation, just relaxation. Now, last but not least, specificity and location of practice. That leads to a task-oriented rehabilitation approach, which is the list in our 12 principles that I mentioned in the earlier slide. Task-specific practice focus on functional tasks meaningful to the individual, requiring accurate assessment and environmental arrangements. So this was sometimes is very difficult in research in neuro. Sometimes the outcome measures that you should use, because not all the patients that are the same, and they come from different environment. And then those task activities, some task is meaningful. So for somebody, for an educated patient, we use Androids. He wanted to have finer movement of his finger so that I could be able to use words and types of pre-words on it. But for illiterate, that's only just for him to call, to pick his phone to make call. So that starts as a meaningful thing. So if you wanted to, there are some activities tasks that you wanted a particular patient to do it, but as long as it's not meaningful to his activity of daily living, then she will decline or she will not be motivated to do it. Then affordance. What is affordance? The reciprocal relation between performer and environment drives movement composition. Exactly. How do you apply task-oriented practice or task-oriented rehabilitation approach? Setting of environment to provide profile affordance, enhance task success, and promote meaningful practice. If you like, just give you an example here. Like maybe you get you have a patient who's a traditional title holder, and you're now asked to go to see him at his palace to be or at his place of residence to give him some care and what have you because of his status. The first thing that you should do, you should look at this environment. You have to provide proper affordance. How is he going to use his hand? What will make him use his hand? It's a traditional title holder. He has all aids that can do all those activities for you. How do you devise means of doing that? Nobody shakes him. If you want somebody to shake him, so you don't shake people. And so how do you do? So you have to set up the environment. Otherwise, your work done will be zero. Then practice condition and feedback control system. You have to understand the relationship between practice condition and the feedback control system. What is practice condition? Structuring practice session, influencing skill acquisition and retention. That's practice condition. Structuring practice. You have to structure using those principles that we made mention earlier. From the amount, the type, are you using whole or part? Are you using variability or are you using constant? Your prescriptions. So you have to structure practice because it will what? Influence skill acquisition. So practice condition is nothing rather than all what we have mentioned in the previous slides, which will help in what? Learning to acquire skill and then to retain the skill for continuous activities of daily living to improve quality of life and improve social participation. So by understanding the practice condition, that will take us to what? Feedback control system. Feedback play a crucial role in guiding motor learning and skill refinement. So like,
Thank you.
Prof said, when you're doing the feedback play a crucial role in guiding motor learning and skill refinement. To give a typical example, when you are particularly doing activities, your eye is seeing it. Other sensory, your perceptors are seen as sending info, and you're not doing the movement. You are not doing the movement correctly. So the system will adjust itself until you attain to what level of refinement. That is just understanding of the feedback control system. However, this feedback control system also affects the type of practice condition, because each practice structure, we have to explore this practice structure to understand how does feedback affect this practice condition. So you are giving mass or distributed practice.
Hello, sir. Sir,
Hello?
can you hear me, sir?
Hello, I can hear you.
Yeah, sir, sorry for the interruption, sir, but I think we need to take a break, sir. We need to take a break.
Okay, so please talk to the coordinator, Hafiz.
Okay, I've talked to him now. He did not respond now.
Oh, she didn't respond.
Yes.
So talk to Jibril Samani.
Okay.
Yes. So I'm waiting.
Sorry to interrupt. Can we please allow the presenter to conclude this session?
Okay. So I think it's better for me to conclude because we have come to the end. It's just very feels like
before we go for another.
Yes, we will conclude.
Okay, sir.
Okay. So now, if you look at these practice conditions, goes along with what? Feedback. What is the implication of doing mass movement, mass activities, mass practice, and distributed practice? Constant and variable practice. It's the same things. But what is the implication? The implication, if you are giving your patient mass practice, may lead to faster short-term gains, but can result in reduced long-term retention because of the way the feedback is going. When you give a distributed practice, the feedbacks promote better retention and transfer by allowing for consolidation and encoding of motor skill. What over time, if you distribute it over time, instead of doing 2 hours massive, you can do it 4 hours with the rest of 20 minutes over a long period of time. But I could remember this is work because there is late Professor Hamzat introduced one per ovary in Nevada. What he does is just get 4 patients, spend the whole day, and he can manage 1 patient in the whole day. And I practiced that. When I was the head of the department, I can take my day seeing 1 patient, and I see how it consolidation and improve skills. So the role of feedback in skill acquisition. There are 2 types of feedbacks: intrinsic, which is internal, and augmented external feedback. Provide information about task performance. Then feedback timing, concurrent feedback during task execution versus terminal feedback after task execution. That means before the activities and during the activity. After the activities and during the activities, 2 feedbacks are taking place from the central nervous system. So providing information, the feedback, where are the feedback sources? The internal, which we mentioned, the inherent, which is sensory experiences. And external augmented feedback provide information about task for you have the therapist will say, oh, move your hand further. No, you are raising hand you are going too faster. That is the external. So these are the 2 feedback. The sensory experience, which there are sensory systems from visual to proprioceptors to others, vestibular and what have you can think of, give the internal sensory experience feedback. And then the external, which the therapist give, could be verbal, could be manual, or look into it later. Then augmented feedback enhances task intrinsic feedback and can come in various sorts as verbal, visual, or physical. Only his heart. You are taking him through the pattern. Then the types of knowledge of result, outcome and knowledge performance execution. The 2 composition and feedback content can be descriptive or prescriptive, passive or active, depending on the learner characteristics and stage of learning. So you look at your patient. What kind of feedback will you give him? Is this prescriptive before he started the work, before he started the practice, or you demonstrate it before he started the practice? Is prescriptive or passive or active? You carry hands, ask him to do it. You are telling him, you are assisting him. So you can choose based on the condition of your patient. How do you optimize feedback provision? Content matters, providing descriptive or prescriptive feedback tailored to the learner's need and stage of learning, which is controlled by the therapist and his skill and experience. Then the frequency, balancing the amount of feedback to promote what active participation and skill acquisition. So the frequency, the feedback should not be too much because it can reduce learning, because the patient will now become dependent on that feedback to participate. But if you give him little, you withdraw it, then you now allow him to actively participate. So the skill will now become what acquired and retained for future activities. Then, how do you enhance motor learning? Using intermittent feedback, providing feedback intermittently to encourage independent problem solving and skill refinement. It's not everything you will tell Joy to do it. You can tell Joy how to, hold her hair, how to fix her hair, how to do something. If you told her how to, to put on shirts, so you don't need to tell her how to, so you allowed her to, to so that to solve some of her problems independently through active participation and self-assessment. Then you can sit with Joy, discuss, okay, if Joy wanted to use her bra, so to wear her bra or to remove her bra, you can have one-to-one discussion, and then she'll be able to do it and solve the problem by herself to learn actively without you taking her into patterns of movement that will lead to that performance. Then tailoring intervention for optimal learning. Individual differences is very, very important. Then adapting practice condition, which is very, very important because it defines the concept. Then the last, which is the last is modeling. Before task performance, you have to model the performance. Modeling reproducing action executed by another individual. Provide information about movement patterns and strategies. It's good to carry out the procedure or the pattern of the movement that you are interested first before you use it. Just like what we do in explaining the procedure of treatment to the patient. So you have to model. Then modeling selection. Choose model carefully based on learner's character and stage of learning. Don't go and describe an activity that the patient is not up to that level in terms of learning, or the patient has no cognition to take that level of learning, or you have to put that task into segment because of the complexity so that the patient will learn. So the essence of all this doing is the patient should have improvement, to learn skill, to live independently, to what? For the activities of daily living. So what I usually remind all those patients that came around, take this thing that we are giving you serious, like just you are going to the doctor, give good drugs. Because if you didn't understand this concept, this principle, so you will not be able to have a patient, and the patient will not attend independent. You paid to come here, you are referred here to come, just to become independent. Then peer models. Modeling peer models, less skilled peers may offer more relatable strategies for problem solving and skills. That's when you are doing group practice. Just like when you're doing CIMT, other task-oriented practice, or circuit task-oriented practice. A lot of research in circuit-oriented practice, you see they have peers that they are different stations. You find out one of the patient is good at particular skill or is better, will encourage the other. So this peer modeling, which is very, very important. And then manual guidance. So manual guidance involves therapist's passive movement to provide some proprioceptive feedbacks. Manual guidance may hinder long-term learning by creating dependency on external cues. But what is the application? Use manual guidance cautiously, ensuring safety while promoting active problem and skill acquisition. So this is why we have to employ a lot of physiotherapists, especially in neurophysiotherapy, so that they can have a lot of time. You cannot do this thing when you don't have good time to assess the patient, to sit with the patient for many hours. And you have to follow the patient regularly for at least minimum of 3 months, or sometimes 6 months, to see what we're expecting to have at a particular level. Then so tailoring intervention for optimal learning, individual differences, task complexity, intermittent feedback, active learning. So these are these are the most important. These are the aspects where. Then the last is a special consideration for neurological impairment. Special consideration for neurological impairment. I'm saying it again and again. Special consideration for neurological impairment. Understanding the slow component of learning. These are a category of patients that come with so many different symptoms. They have inherent fatigability. They always get tired. Apart from the physical activities. No, it's one of the challenges, although most of these neurological patients that presented. And then they have slow component of learning. Sleep-dependent aspect involving biochemical and structural changes. Slow component of learning. Sometimes plasticity, the capacity of the brain to modify structure or function in response to learning or brain damage. We have to understand the plasticity. Something that takes a lot of time. And then the last is the last is this sleep disturbance in neurological condition may impact long-term skill learning. It is when you are staying with this patient for 4 or 5 months in a day, in a during clinical session, you take 4 hours, 3 hours in those specific neurological patients that are having special problems that are not making progress in the clinic. So if you give him some special attention, you find out this kind of problem. You find out he doesn't sleep at night throughout, or he sleeps in the late part of the night, and he comes to physiotherapy clinic in the morning. How could he perform any activities? He cannot do anything. So what you do after giving him them, you do some activities. You now ask him to sleep for 30 minutes, 1 hour also. She'd wake up, eat something, and do snack something, and then do another activities. So you'll be able to. Especially, I'm saying in court, difficult patients that present with these syndromes. Patients that present with these typical symptoms, especially in stroke. So they are not making progress in a daily routine clinic unless if you take them one by one and give them attention and give them a lot of hours. Then you find out they have this fatigability, they have this sleep disturbances, they have now some pains and what have you. And there's even some have even nutritional problem because they are not eating up to their capacity that they can get the stamina, the capacity, nutritional support to carry the activities you wanted to do to them. So you have to look at that. Sometimes we don't see that in literature, but what we see in our clinics every day, you find a patient is not eating, they're not getting the strength, the nutritional support for him to carry out all the activities and the learning process, despite all those inherent problems that he's manifesting based on this injury from the central nervous system or peripheral nervous system. So this is the end of my presentations. So I'm now waiting for the house to bring some money. Are you around? Hello.
Thank you, sir.
Hafiz.
Thank you, sir, for this presentation. So anyone who has a question or comment, you can do it now. If there is no comment or questions, we can go for break.
So the house.
Mr. Hafiz, what time are we coming back?
Like 2:15, like one hour break. 2:15.
Okay, thank you.
So thank you, my dear colleagues, for
let's come back by 2:15.
Interact with you. Thank you.
Happy please, can we have these slides available?
Yes, it is in the group.
Oh, okay, because there was one I downloaded, but I couldn't open. I don't know if it's one.
Okay. I will share it again.
All right, thank you.
You're welcome.
Thank you.
Okay. Are we on question and answer?
Yes, you
Break.
can ask.
We're on break, but if you have question or answer, I think you can.
Thank you, presenter, sir.
Yes, sir.
I enjoy the presentation.
Okay, thank you.
Over here.
Thank you,
Sorry,
Dr. Lawal.
can I quickly ask a question?
Please, you can do, sir.
All right. Talking of the plasticity now.
Yes.
Now, here it's common to the neuro unit that there are some patients, especially stroke patients, that present to you at late phase, maybe even 1 year, some even 1 year, 6 months post-stroke. Now, as a neurophysiotherapist, in line with plasticity, what do you think we can achieve with that? 1 year, 18 months after stroke?
So the previous knowledge that we had, sometimes it's after 3 months, 6 months, 9 months, or a year also. We expect the patient has reached a plateau of recovery. But thereafter, there's some research of single patients that were done after 1 year or 2 years and made some recoveries, improvements in their this thing. So because of this concept of neuroplasticity, people, because the literature is coming off with a point or an indication that patient after even 2 or 3 years could make progress. I've seen even a patient after 5 years, though it's not it's a single study. It's not what I mean. The level of evidence is low, but I've seen a patient of after 5 years that was attended and made some improvements. So it's something that's now being encouraged. Really, even after, and even you can look at it, you can have a patient also after many years when you can look, you can find out that now this advancement of knowledge and different and ability of better prescriptions. You can see some patient can make little progress, or you can do some even compensatory things, or you can do some adaptations for him to live better. Especially if in the early stage you couldn't have better rehabilitation services. Thank you.
So thank you so much, sir.
Yes.
We are now on the break.
In the break.
Thank you so much.
Thank you. I appreciate you.
Next lecture at 2, right?
2:15.
2:15. Okay. Okay. So thank you.
Thank you.
How much go back? How much I will give you?
Hello, good afternoon, everyone. Welcome back. Dr. Bopper will join us in the next 5 minutes, please. Sorry.
Please, are we back? I'm not hearing anything.
Yes, ma. He's joining very soon. In the next 3 minutes, he will join.
Okay.
Yes. Okay. I don't want to answer the question.
Sorry, please. Now he is. Now the presenter is. Yes. Disconnecting.
Hafiz, please let me know if he can't join. Then maybe if I can.
Maybe sir, you can continue. When he wants to join, he will pick up from where, because time is really going.
Good afternoon, everyone. My sincere apologies for joining the meeting late. This was due to a problem with the network. I have to use a different network and I've even tested this before commencing the webinar, but I think there's still some problems before commencing. So, but we thank God I'm able to join. So let's go ahead. Thank you everyone for your patience.
Yes, continue, sir. We're hearing you. You can start.
Okay. Good afternoon once again. Sorry for the late commencement, like I earlier mentioned, is due to some technical glitches about the network, but we are now back on track. Thank you. We thank God. So yes, you are welcome to the Ray Medical Institute, Ray Medical Rehabilitation Institute webinar series titled "The Principle of Assessment and Rehabilitation," which I'll be taking the aspects of assessment or neurological assessment of neurological conditions by name, I'm Muhammad Ali Abba, Department of Physiotherapy, Bayero University, Kano. This topic is a very wide topic, but I'll try my best to make justice and discuss the most relevant aspect of neurological assessment. So by way of introduction, yes, neurological examination is usually intimidating. Yes, whenever we hear of neurological assessment or examination, we sometimes even begin to think, where do we start? What are those things we need to do? And what are the expected outcomes and so on? A lot of things comes into our mind. And also that we might probably make some errors in the assessment. What could be the consequences of those errors? And a lot of things come into our mind. So when one is thinking of neurological assessment or examination or diagnosis, some of the key issues or the key points in the assessment are the good skills in history taking. Yes, history taking is very, very important and is very key, because when key things are missing in the history, this means a lot is going to be missing from the examination that will follow, from also the diagnosis that will follow after, and of course the management. So it is very, very important. We need to sit down and learn the skills of taking good history, then following the examination. Learning neurological assessment takes time. Sometimes we want to rush it, that we want to learn it within short time. We want to learn and apply it within the very shortest time, and sometimes it's not possible. We have to pass through a lot of stages to learn these things. So the basics are there that we need to learn, then apply them in the clinic over and over. That is what will help us to apply it effectively, the assessment. In general, there is no ideal neurological examination technique. Yes, because sometimes there could be a lot of variation in the assessment. Another thing is not the variation, it's just the approach, because day in, day out, one has learned that if I do this, it may also give me a similar outcome with what was or what is termed as the conventional technique or the usual technique that has been done. So, and also the methods are evolving. So that's why we say there is no ideal thing, or there is no ideal neurological. There is not that there is no standard. Yeah, there's a standard for every part of the body, for every system that we need to assess, but these things varies among patients, among conditions. They vary among different the different background of the patient, age, gender, and many other things. So, like I said, they are evolving, so they are changing over the time. There are a lot of upgrades. There are a lot of newer techniques that are coming up all the time. So, perhaps so that's why there are a lot of changes coming up. So because we said earlier that it takes time, so you need to take your time. No hurry. You can learn it on subjects, on colleagues, on people at home, on subjects, on friends. You can try this thing over and over until you perfect it. And there is no such thing too that assessment would commence at day one and complete at day one. The next visit the patient is coming, you might have thought of something else, and you may change your direction of the assessment. So when you have a certain direction in the first day that the person comes, and maybe the second day, you might have a second thought of what to assess further, and probably the outcome that may come, the outcome that will get revealed from the assessment. So one has to formulate hypotheses and think of the expected findings, like what I just said now. So you have to formulate hypotheses that this is what the patient presents with, A. Then probably if patient presents with A, B, C, these are the things that are probably the conditions, and this is what you expect in the further assessments that you have to conduct. Then the consistency, you check. The presenting complaints, the history the patient is given, the examination, your hypothesis that you generate the expected findings, the examinations that you conduct, physical examination that you have to conduct, are they consistent? If not, then something is missing. Then have to go back again and formulate another hypothesis, check another set of expected findings or outcomes. Again, check the consistency. Also, the reliability of all these assessment approach and techniques that are usually involved in assessment of patient too. This is key. So, are they reliable? Are they valid? Are they reliable? Are they valid for Nigerian patients? For example, the paper and pencil outcome measures that we can use, even though they are lengthy or they are cumbersome sometimes, but we need to find out that these particular outcome measures, are they valid? Are they reliable? So in general, the psychomotor properties of these outcome measures, if they are developed and used in China, might not necessarily be possible for us to use it in Nigeria. First of all, the language. We need to cross-culturally adapt it to Nigerian language. Then the culture, yes, that's why we have to cross-culturally adapt it, not just the language you translate, the culture you also look. There are some things that are peculiar to the Asians or the Chinese, but are not peculiar to us here in Nigeria. So we have to also look at those things. So the other aspect of the psychomotor properties, is it instrument that if you use, another person will also come and use it, and you will get almost similar outcome? Is it an outcome that you use today, and after some days, which you are not expecting to see any change, and you come to realize that there are some changes, then it means there are some problems with that instrument? Or is it that the instrument is supposed to detect some changes after treatment and is not detecting? So that's why the instruments one is going to use need to be subjected to this psychometric properties testing. And most of these things, they come when we check online studies that have been conducted on those outcome measures, the test, or when they are being used, they reveal the psychometric properties. So we have to look for the studies that have been conducted in Nigeria, and this will help us in choosing particular instruments. The social demographic characteristics of the participants would also help us in checking. For example, is it an instrument that was developed for older individuals, and you now begin to use it on a younger generation or younger patients? Probably you might not get anything, or you might get contrary to what you are looking for. Is it instrument that is available for so many reasons we have to look at? So we need to apply clinical reason. I've already started talking about the second item here on this page, the hypothesis testing. We have different forms of ways of clinical reasoning, deductive approach, which usually you have to develop a hypothesis and you have to test it. You have to go back to what you have learned, what you have read, what you have practiced, and see whether they have correspond what you have with you in front of you, and you have to screen over and over many things to get it. The other method of the or approach of the clinical reasoning is what is usually conducted by the or usually done by the experts. That's the pattern recognition. Just that this is a patient that this patient in front of me has also presentation that of a patient I saw 3 months ago. And what we did in those assessments reveals the patient is having so diagnosis. So over and over, when you are meeting of such kind of patient, it should be easier to say that this is the diagnosis. Most time without even going to go for further tests to reach a diagnosis. So those are pattern recognition. So there are many approaches to the clinical reasoning. I think this is a very wide area, a very wide topic that needs to be discussed. And everything or every assessment that one is going to get engaged with, that this is evidence-based practice. This is what evidence has revealed. Based on what it's just summary of what I've discussed earlier, the psychomotor properties, the level of evidence of use of that instrument, how good is it, usability, utility, many things that you have to put in place to make sure you're using the appropriate instrument for that particular patient. It might be appropriate, but not for that particular patient. You have to look for the appropriate one. So that's why the selection is very important. So neurological examination can be used as screening tests or for investigative tool. When they are used for screening tests, usually they are for patients that you don't expect any neurological, they are non-neurological conditions, but you don't expect to see any neurological symptoms or features of presentation, but you screen. There could be a neurological condition. Investigative is when there is that this is a neurological condition, just that you want to dig further and find out the type of problem, the severity of the problem, and so on. So it depends whichever way you want to use it. I just want to also mention at this juncture that when we say neurological investigation or assessment, it's not only applied to or limited to just neurological conditions, because there are non-neurological conditions that comes up with neurological features. In most times, we see a lot of conditions of patients like that. For example, we can see diabetes mellitus or diabetic patients coming off with peripheral neuropathy. Diabetes mellitus is another set of, it's a medical condition, of course, an endocrine problem, but you see patient coming with peripheral neuropathy. So, or several kind of conditions could occur as such. So there are a lot of challenges. First of all, we have mentioned it's difficult, it's intimidating. It takes a lot of time to learn, a lot of time to apply, and to learn the basic skills and so on. But yes, while also conducting the investigations, these examination assessments are not without challenges. Yes, There are lots of challenges. These are just to mention few. We may come with the intention to assess patients, then they're having problem with their mental state or their cognition. Come with mood problems like depression, or they are delirious, they are confused, that they are not even comprehending what we are trying to tell them, or what we are trying to get from them, the information we are trying to obtain, or the feedback. They are confused, they are delirious, or they have a cognitive problem. They cannot focus, they cannot pay attention, they cannot concentrate. Anything you tell them, they cannot remember. So loss of limbs. Most of this, we compare upper limb, for example, affected, unaffected. We compare lower limb, affected, unaffected. Or most of the time, we just learn the techniques on upper limb. But we may have a reality patients that are having, they have lost limbs. Yes, due to amputation or other reasons or congenital problems. So we will be able to compare. Or the only technique we know for upper limb, we don't know how to apply for the lower limb. So we have to, then we face with a problem, challenge. Sometimes congenital problems that patient will be born with, will have hearing problems. So we will not get appropriate feedback. They could have visual problems that they were born with, many other problems. Then we will not get appropriate feedback. But most of the time, that's why we are taught special education, special pedagogy, so that we can interact with such kind of patients. Speech and language problems, just like in stroke patients and unconscious patients too, will not be able to get all information from them. So there are a lot of challenges. Other challenges would include the basic knowledge of each and every basic knowledge of each and every condition, of course. Then the basic skills for the assessment as well. Anatomy, physiology, they're all important. The pathology, the various conditions, signs and symptoms, and the instruments or the methods or the approaches for the assessment. So that's why we said it takes time. You build one step at a time. So let's start with neurological history taking and evaluation. This is one of the, we have mentioned in the first or second slide that this is the key aspect of management of neurological conditions are the history taking and the neurological examinations. So we are starting with the neurological history taking. History is the most important part of the neurological evaluation. Yes, of course. We said earlier that if one missed key points, key issues, key information from history taking, might miss the whole information and will not be able to achieve or arrive at the right diagnosis. And of course, the management too will not be the appropriate. So that's why it's very important to pay attention to this. So the general approach to the history is common to all, but which part of the history, which is that is most important, vary according to the patient and complaint. The approach are the same, but where you need to dwell on, where you need to take as the most important vary, depends on the particular complaint, because even though they could be the same condition, but they may come with different complaints. So some key aspect of the neurological history taking are the background information, the history of present complaint, neurological screening questions, and the history itself. And time inquiry and general examination, synthesis of history and differential diagnosis. Yes. So starting with background information, we look at age. What is the age of the patient? It's very, very important because what is applicable in certain presentation, the age may give you another direction, not also the direction of assessment. Yes, the instrument that you have to choose for, or the outcome measure you have to choose might vary. For example, assessment of history taking of a geriatric patient, for example, and somebody who is young or middle age, their complaint may not be the same. A geriatric patient must have already been used to, say, pain. Somebody who's young is not used to pain because probably doesn't have any joint pain, doesn't have any chronic disease, but somebody who is elderly already must have developed so many joint problems, some neurological conditions that over time, this were taken as normal, or it's getting used to it. The way they will respond to questions, the way they will respond and give you some answers and feedback could be different. Another example is, let's say, depression. The depression for a young person could be, and for that of older person, for that of the other person could be, they have to do with health related challenges. Let's say for that of younger one, could be just related to some other life issues. Maybe person has lost some wealth. Maybe is having challenge with spouse, relationship, family issues, finances, job, and so on. Somebody who is 80 is not worried about job, is not worried about relationship, is not worried about so many of those things. So that's why any instrument you are looking at, you find out which of the population is being developed for, and which of the population also being adapted. You can also read that the questions inside and see which are very important to which age that you have to take. Then gender. Gender is also important. We know that there are certain conditions that are related to males, some are related to females, some are related to both. Yes. So we also have in some countries, in advanced countries, we also have other gender orientations, which will also present with certain direction of condition or with certain risk factors. For example, let's start with the females. Females, for example, that have reached menopause. This also combining age and gender. Women that have reached menopause already are at risk of stroke, for example, but women of childbearing age are not at risk. And then we have, let's say, the transgenders, male crossing to female gender, female crossing to the male gender. They receive hormone replacement therapy, which also places them at risk of stroke and other cardiovascular diseases and other neurological conditions. Same also with the women after when they are menopause, whether they receive hormone replacement therapy or not. Then handedness, the patient is right-handed or left-handed. This tells us about the other things, other anatomy that that will help us. For example, the speech, whether it's going to be affected or not, on which side of, for example, we are talking about stroke, on which side of the body the stroke occurred, and to tell us if the patient is right hand or left hand. We are expecting speech problem, or during our testing, assessment of muscle strength, for example, under the motor system, that we should know that not be the same. If, for example, that's if the patient is a right-handed, the coordinated pattern of movement on right hand we expect that of right hand to be better than that of left hand, of course. So these are all key in assessment of patients, and also in the management, planning the management as well. So occupation, either the current occupation of patient or the previous occupation, this tells us also a lot about what has contributed to the patient's current condition and problem, and what could be the future also direction of the patient's current condition. The occupation also tells us, or also it has to do with during management, that how will the patient go back to his work, how would the work be modified, or probably the work has to be changed completely for one reason or the other because of the severity of the condition. So these are all important. These are just some example of background information that we need to take and how important they are. So the presenting complaint of the patient, you speak in terms that the patient will understand very well, and you need to also watch the patient as he tells you information right from the background information, presenting complaint, history, downwards, so that you don't derail from where you are heading. Some patient want maybe just have the opportunity to just say to go outside the context, even though some things may be important depending on the patient's conditions. Maybe patient is depressed and is trying to tell you some of his or her problems. Maybe with that bottling up, it will help reduce a bit of the burden of the problem. But most important is you need to stay on task, not to derail too much. So you tell the patient, tell me about it from beginning. What is the problem? Tell me from the beginning. So we tell you from the very beginning that it started on so. This is how it started, and so on. So, like I said, you have to be on the direction, but you don't interrupt. You interrupt minimally. You don't dictate the whole the whole thing, but you should allow the patient to flow, but shouldn't derail. So you should get the precipitating factors or living factors. They should also tell you direction of the condition. Time course. Is it sudden? It's just within few minutes, few seconds, or is it over hours, over weeks, over days, months? How is the progression? Is it continuous, intermittent, or is it stabilized? How do you you ask the patient all these things, because all will have to they have meaning. Something that comes usually sudden, you have to start thinking of conditions that have to do with of vascular, they are of vascular origin, of course. Yes, the progression is continuous. It's continuous, is stepwise, is this stuttering. So it will also give you direction. That is it inflammatory? Is it infection? Is it as a result of neoplasia? That's cancers and so on. So these are all important. Like I said, when it's sudden or acute, we usually think of vascular conditions or conditions that have to do with vascular origins. Yes, subacute, you think of inflammation or infections. Yes. Is it it has been progressive? Progressive, yes. You think of neoplastic condition or degenerative conditions, of course. Yes. So these are basically important. You look at how it started and how it's also progressing. I say also if it's stepwise, it's usually vascular, for example, in vascular dementias. Yes, they're usually stepwise. So these are some key information. So past medical history is to understand the etiology, to discover the conditions associated with neurology. Yes. There could be, I've mentioned also that there could be conditions that will have some presentation of some neurological manifestations or presentations. Example, the diabetes mellitus. So history of diabetes mellitus can give you some information. History of hypertension can give you information about stroke, about dementias, about TIA, about many conditions. Surgeries can give you information about, let's say, neoplasias, maybe probably had cancer and had surgery. So from there you can think what type of cancer is it? It is cancer that has metastasized. So which area was affected? Which area could have metastasized to? So this could help you. So previous treatments that patient has received, previous investigations also will give you a direction of what the condition is or how it started initially. So you generate you try to find out the current state of the neurological condition. Yes, you generate hypotheses and you test the hypothesis, then you go for neurological screening and come back to see if the hypothesis is accurate, then whether your testing expected outcomes are the same. So drug history. This can also act as a reminder of some patient may not be able to tell you some condition because maybe in the hospital they were not told which condition is. Maybe there was no time for them meeting the doctors to inform them that this is the condition, these are the things, or they may not want to say it. Yes. So they tell you that I'm taking so drug. So from that, you'll be able to know that, yes, these are they have so condition initially, or they are currently having so condition. You may not receive referral from the professional, so you may not have complete information. I've mentioned also, okay, I was talking about hormone replacement therapy. This is oral contraceptives, of course. So some women may not even mention oral contraceptives. You can ask them about oral contraceptives. Yes, some drugs like steroids, benzodiazepines will lead to some neurological conditions. So you also take history of whether they are taking such kind of drugs. Family history also, they are very important. Some neurological condition may have background of genetics, yes. Some not. So you should get history from parents. You ask them of history of such conditions. that is their parents, whether they have such problems, their siblings, whether they have such, they have any other, they have any other neurological problem, or their parents have history of any neurological condition or neurological problem. That will tell you, that will help you also in your assessment and your screening. But some patients may have their parents who passed away, so they will not be able to tell you such information. So those are patients that you also need to work further and find out the problems they are having. The patients that are alive, when they will tell you that no, there's no any problem with our parents have no any neurological conditions, or they have that, this and that. So that will give you a direction. So because if once parents passed away, you could also ask them of what could be the history of maybe the condition and the reason for the death. It could be a neurological condition which they could inherit. Yes. So a lot of questions can arise from family history, social history, the environment, the finance, their family members, their carers, how they interact, how you can plan your managements based on their finances. Are they currently employed? Are they gainfully employed? Do they have any, they can afford the management? They have to change their occupation. They have to it has to be modified. The environment also, what could be done in the environment. And it could be that they have been exposed to certain toxins in the environment that lead to certain conditions, or lead to the conditions where they are, and their relationship with their carers. And the other problems. So interpretation of neurological history and the synthesis of neurological exams require experience. Yes, it takes time to develop the experience and the background knowledge. So when synthesizing the history, yes, you begin to think that the information the patient is giving based on anatomy, where could you place such problems? Or is it that you can synthesize that it's a certain syndrome? Will you also synthesize, be able to find out the based on cause, based on etiology of that condition? So you'll be able to put them together and find out. So based on anatomical synthesis, is it that what the patient is telling you, that it could be that it is a lesion of nervous system? Of course, is it actually nervous system problem? Is it nervous system problem that has to do with cortical region, subcortical region, spinal cord, nerve roots, the plexus? Is it at the level of the nerve, neuromuscular junction, or the muscle that's been supplied by the nerve or the nervous system? Or is it that the lesion is a single lesion, or is multiple, or is diffuse from the history you are receiving? Or is it that it has formed a certain recognizable syndrome? For example, Parkinson, you know that there's a bradykinesia, there's a rigidity, there's a tremor, this is Parkinsonism. So, and so on. Or is it because could it be you're able to trace the causes, etiological region, the etiological reason, synthesis? Will it be genetic? Will it be congenital? Will it be inflammatory? Neoplastic? I think we have mentioned some examples while talking about the presenting complaint. Will it be degenerative? Will it be traumatic? Will it be metabolic or toxic? Or yes, could it be traumatic, metabolic, and toxic? Could it be endocrine? Will it be of vascular origin? All those things are important. So let's this is just in summary about the some of the principles of the neurological assessment that one needs to get engaged with before beginning to go for physical examinations. So before we commence the physical examination, we are just going to, what we are looking at is the various systems and body part. So we are going to start with this is just a summary of what we may be looking at: mental ability or mental states, motor system, sensory system, balance coordination, gait and mobility, autonomic nervous system. These are just some of the examinations, system examination we'll be looking at. In neurological examination, there are much more. Yes, but we'll try to look at some in this category. So let's begin with the neurological examination of mental ability or mental state. There are a lot of things that entails mental ability or mental states. One of them is mood change. We have the mania, which is the excessive happiness. We have the depression, which is low mood. We have the cognition, which is composed of several domains, which include memory, orientation, attention, perception, language, many other things we can talk about, abstraction, and many of them. So delirium also, delusions, hallucinations, and many others you can talk about. We'll just look into these 4 or so. So I think I've mentioned also earlier that some neurological conditions are as a result of the neurological condition itself. Some are from other medical conditions that result in neurological presentations. So also with mental states. Some mental disorders or problems could arise from neurological diseases themselves or neurological disorders, one which is dementia. Some could be some psychiatric illness leading to neurological symptoms, such as anxiety leading to panic attacks. Some could be psychiatric illness secondary to neurological diseases, for example, depression in stroke. So we know that most times at the early stage of stroke, at acute stage, there is usually depression, or there is usually cognitive impairment. So looking at mood. Somebody maybe inadvertently wrote something on the screen, which is causing some obstruction. Sorry, I don't know, one of the audience, I think, did that maybe mistakenly. So please, can we all see the screen? I think it's okay now.
Yes.
So,
Yes, it's okay.
It's okay.
I think someone made a mistake and made some diagrams on the screen. So as I was discussing, yes, we said that yes, some condition could be neurological and come up with psychiatric or mental state problems or disabilities. So one of them is the mood we've talked about, which is, and we are looking at depression. There are some just key questions you use to screen. You know, we said you can screen and you can go into investigations. We say in the past 2 weeks, what have you been talk about what the person usually do that he enjoys or she enjoys. If they have lost interest in such things, there's isolation, withdrawal from public, and many other things you could observe, then you can go further to investigate using many investigation tools for depression, like the Beck Depression Inventory, the Center for Epidemiological Studies Depression Scale, Geriatric Depression Scale, Zong self-rating depression scale. I've mentioned too that last time that there are different scales for different individual types of individuals based on their age and conditions. There's also other ones like patient health questionnaire, which are usually for patients with medical conditions, because when you're asking patient or people with depression, the question you ask somebody with medical condition, the responses you get are different from the questions you ask somebody who has no medical condition. It's just that the person was hit with some life-changing events, like relationship problems, marital discord, issues with finances, loss of job or change of job or stress during work, and many other things. So you can see you have to look at the instruments, what they are valid and reliable for, then you apply. also age. You can see that we have geriatric depression scale that can use for older individuals. So when somebody is depressed, certain instruments may not be the same for somebody who is depressed without medical condition or person that is depressed with a medical condition. For example, stroke comes up with depression. The question you ask them, they will based on, they will have to do with the stroke that they suffered. But somebody who, for example, lost his or her job, or somebody who lost finances and so on, the question could vary and so on. So that's about low mood or depression. Then there are delusions and hallucinations. Yes, of course. There are so many neurological conditions that come up with these presentations of delusions and hallucinations. And they are usually false beliefs and false perceptions. We have like grandiose delusions. Somebody will tell you that they have some superpowers, or he's a so-so person, or he was from another universe, or a lady can claim that she has about 50 children or 60 children. Or somebody can come up and say that he's the president of the country, or is the governor. So these are examples of grandiose delusion. There are various types of delusions. So there are false beliefs, and hallucinations also. They could also be of several types. They could be visual. Somebody will tell you that he has seen somebody who has passed away over 10 years ago. He could tell you that he has just seen his great, maybe the grandfather has passed away. He can tell you that he has seen his grandfather. He has seen his spouse that's passed away many years ago, or he has seen horses just passing through his room, and so on. So we tell you that he could hear people talking to him. That's the auditory hallucinations. We'll tell you he's having some taste in the mouth, which is gustatory hallucinations, and touch, many other kind of hallucination, and many other kind of delusions too, that could be erotomatic. Somebody will think that a certain lady is in love with him, or a lady will thinking that a certain guy is in love with her, which is false. And somebody an example of another delusion is the persecutory delusion. Somebody will tell you that he's suspecting so person that is attempting to, or is planning to kill him or kill her, or is trying to do something harmful to him or her. So all those are kind of delusions and hallucination, and these are very common with dementias. Yes, of course, especially that of Alzheimer's disease. They are very, very common. So they are very common usually in dementias, delusions, and hallucinations. So that's why they are important for us to look into them. So another aspect we'll be looking at is the cognitive aspect of mental state or cognition. And we have said earlier that it's composed of various domains, such as memory, orientation, attention, executive function, abstraction, language, many other domains. So, for example, asking questions or screening for memory. But we said you screen sometimes, then you now come for investigation. So screening for memory, you ask the patient, what has he taking for lunch in the morning? What has he taking dinner yesterday? You could ask some basic activities that one could be able to remember, of course. Yes, but some other factors can affect the recall. Yes, stress, depression, many other things can affect somebody will be unable to recall those things. Orientation, you ask individual orientation in place, time, and person. That where are you currently? Tell you is in the hospital or is in the social place. What time of day is it? Is it morning or afternoon? Yes, to tell you. You could ask also the date, the day, year, the month, and the year. Also, you could ask such things. Then attention. There are various ways to assess also attention. You could observe how the patient is responding or is connecting while you are asking him all these questions, while you are going through the history, going through the assessment. You see that they are easily distracted. Any little thing that is going around, they have to go, they have to turn and watch and observe what is happening. And for a very short time, they move to another activity that they have to observe. So you could see that they will not be able to pay attention to you and give you the appropriate responses. I've mentioned earlier that these are one of the challenges in neurological assessment or examination. There are many other ways to assess it also. As executive functioning, which is the ability to initiate tasks, to plan, of course, to initiate tasks, to maintain the task, then to terminate. You could see that attention, yes, most of our stroke patients that have problem with cognition, we could see that they cannot we could see that they have problem, they easily get distracted. So also with executive function, you give them a certain task, they will just be standing and looking at you because they don't know how to initiate those tasks. And when they start, they don't know how to stop. They will just continue to do the task until you ask them, until you just hold their hand and ask them to, you just tell them to go. So those are issues with executive functioning. I think for attention, there are different ways that can be assessed. One example is the stroke test. Here we can see on the screen. We could see that there are words here and they don't reflect the name of the color. Yes, the name of the color and the color do not tally. We could see here the first one is purple, but we have red. And the second one we have yellow, but it's color blue. We have red. It has to take a great attention to respond and do this appropriately. So the question will be to say the appropriate color, but the person will be telling you purple instead of red and yellow instead of blue. So they pay attention to the color, not the name of the color. So you can see this, if somebody is easily distracted or is not paying attention to say this right. You can see from the beginning to the last word written there, orange, which is in black. So this is one aspect of assessment of attention and executive function that I mentioned, which involves planning, initiation, maintenance of tasks, and of course, at the end, termination. So this is an example. You ask the patient to start from 1 to 2, 3, 4, 5, 6, 7. Some will start at 1, 2, 3, 4, end at 7, 8, then connect 8 and 1. So in a real sense, you can't connect 8 and 1. So it means you have failed the task. So they could not be able to terminate the task. They may even continue and be going around again. So this is trace making test. We have the trace A and we have the trace A and B. Sometimes we have a combination of numbers and words. I don't have a picture of it, but we could see it on the Mocha test. Yes, it's available there. So this trails making will be used for assessing attention. This is another complex one in which is combining letters and numbers. You see that we have 1 here, then 1 will be linked with A, then A will be linked with 2, then 2 will be linked with B, B will be, and so on till the end of this. This is more difficult than the first one that I've mentioned. So we can progress with the assessment to make it more difficult. It could be just numbers, it could be just letters, it could be combined. And this is an example. And this is an example of overall assessment of the cognition, not just the domains. It depends on what you want to assess. This is overall domain assessment. You can see the executive function here on the MOCA test, which we have the trails making test, the trails A and B. We can see we begin at 1, we move to A, we move to 2, B, then we move to 3, C, 4, D, 5, E. You can see they have made it clearly that the task should end at E. So if the patient is not paying attention, he might continue from E, we join it to 1 and go back again and over. So it's showing that there is some problem with the executive functioning, the certain stages of the executive function, which we have the initiation, the initiation, planning, initiation, completion, maintenance, and completion of task. So we can see the visuospatial function also. Patient will be asked to copy this cube or this box, and there will be scoring there, which is 1. The executive function also is called also 1. Then there will be clock drawing test, which also which also assess another component of cognition. It could be used to assess spatial neglect, yes, plus other tests like line bisection test or star cancellation test, which are also used for assessment of neglect. Yes. So we ask the patient to draw 10 past 11, and it has 3 points, which the contour has 1 point. The numbers, the contour of the clock has 1 point. The numbers in which the patient will write, the person could write 1, 3, 6, and 9. Sorry, 12, 6, 12, 3, 6, 9, 12, which is okay. The patient can write 12, 1 to 12, sorry, 12, then 1 back to 11, then 12, yes, which is okay. But the contour is also important. It should look like a clock, yes. I could see some questions. I will respond to them later. Numbers, yes. Then the hands. The patient shouldn't draw the hands of the same size. Yes, should be able to differentiate the long arm, which is minute arm, and the short arm, which is the hour hand, and should be able to place them strategically at the middle, so that they will not just be on the one side or on the other side. That indicates problems like neglect. Yes. So yes, we have the naming, which is the yes. Patient should be able to name these items: lion, rhinoceros, camel, or dromedary, which is also another aspect of cognition assessment. Then recall or memory. This one, we can see the first memory or recall we could see is just for the patient to be able to have them in mind. These words, we can see there are 5 words there: face, velvet, church, daisy, and red color. Yes. So you should tell the patient, please, I'm going to tell you these words. Repeat them. You should read and you should be able to repeat them. Yes. So the first trial, you should be able to do them. If it's not able to do that, you can do it for the second trial. There will be no point assigned to this particular category, because after passing through test of attention, language, abstraction, then we can see a section of delayed recall. That is where we are going to assign points to the patient when the sorry, I'm distracted with some questions, with some messages that I'm receiving. So messages from the audience. So yes, part of the naming, we are going to yes, for the first question that somebody asks, is it feasible to administer the trace test and MOCA test to patients that are not lettered? Let me complete the MOCA test. Then I will say some of their limitations and some ways to go about their limitations. Same thing with the next question too, was on trace making test. Also, let me also complete, then I'll be able to respond to them. Thank you very much for the question. That means we are following up what I'm taking us through. So the aspect of naming, so the aspects of memory, you tell the individual yes. So we can see that there are face, velvet, church, daisy, and red. These are the 5 items that you want the person to have in his mind. Then you should be able to respond in the first trial or the second trial. Yes, you record, you tick if it's able to answer you correctly. Yes, then you are not going to score. You can see there at the end that there is no point attached to this particular aspect. The point is going to be scored here under delayed recall. So after passing through attention, language, abstraction, then you ask the patient, can you remember those 5 words I told you earlier? Yes, if the patient is cognitively intact, especially in the aspect of memory, then you tell you, yes, I can recall. Okay, let me have them. Face, velvet, church, daisy, red. Excellent. The person will have 1 score each, and that will be total of 5. We can see at the right end here. 5 is over 5, maximum of 5. Yes. If it's not able to recall 2, then we'll have 3 points out of 5. If it's able to recall 1 only, we'll have 1. But there's another aspect we can see here, which is the memory index, MIS. I'm trying to check here. There's a section here which is memory index, MIS, memory index score, which is MIS. That is, if the patient is able to recall, that is the scoring is different from these 5 that I am talking about. The memory index score is different. So if the patient is able to recall all the 5 without Q, then this person scored 15. It's going to be 5 times 3. The patient scored 15. If the patient is able to recall with some help, you have to give him Q. This Q will be that if he's not able to recall, let's say face. Face is not the face is the word that is not able to recall. So you tell him that can you remember is a body part? The person will say, oh, sorry, it's face. Or let's say it's velvet. You say, can you remember it's a type of clothing? Person will say, oh, it's velvet. Or you say it's a type of building. Person will say, oh, it's church. Or daisy. It's a kind of it's a type of flower. Say, oh, daisy, I remember. Or it's a color I told you. The person will say, oh, it's color red. This is when you give cue. This is how you give the cue to the patient. Or if patient cannot recall with cue, then you have to give a multiple choice. If the patient is able to recall with cue, then the scoring will be by 2. Here, the first one is multiplied by 3. The second one is multiplied by 2. The third category is multiplied by 1, which is you have to give multiple choice. For example, the patient is unable to recall face. Then you give a multiple choice and tell him that okay, choose from these options: head, neck, face, hand. The person will say, oh, it's a face that I'm not able to recall. But unfortunately, there could be also a reason that there could be a stage that the patient cannot even recall anything. Then you score 0 for the patient. So if it's a velvet, you give also multiple choice for clothing materials and you place that velvet in between, then able to recall. Or you mention different kind of buildings, school, hospital, many things, then should be able to recall. Or different kind of flowers, then include daisy in. Or different kind of colors, and you include red color. If he's not able to do that, then the score is 0. Then going back to from memory, then we have attention. We can have subjects has to repeat them in the forward order. Yes, I forgot to mention that there's also another way to assess attention, which is a digit span test. This is an example of digit span test. So, person instruction should be given or will be given. Subject has to repeat them in the forward order. So you should mention to the patient, you have to mention these numbers in forward order: 21854. So he's supposed to repeat the way you said it: 21854. The second one is backward. We have the digit span test forward, then digit span test backward. So the forward is you should be able to say it the way you say it. Then the backward is subject has to repeat them in the backward order. When you mention 742, then the patient should be able to understand and say 247. That's in reverse order. Then still under attention, this is another instruction that you have to talk to the patient. These are letters that I mentioned: F, B, A, C, M, N, A, A, J, K, L, B, A, F, A, K, D, E, A, A, J, A, M, O, F, A, A, B. So you are going to tell the patient to tap or clap whenever you mention letter A. You are going to talk it, you are going to say the words, you are going to say the letter, slowly in a speed of, let's say, 1 letter per second. For example, F, B, A. So whenever you come to letter A, the patient should indicate that you are on letter A. He should respond. Yes, I mentioned digit span test, SPAN, digit span test. So when I've mentioned it, that if a patient is not able to after the cue, after the category, after the multiple choice is not able to do that, then you score 0. You multiply by 0. We say the first score you multiply by 3. The first category, the second category you multiply by 2. The third category you multiply by 1. If it's not able to respond, then you multiply by 0. So then that is under attention. Another activity under attention is serial 7 subtraction, starting with 100. You ask the patient from 100, subtract 7. That will be 93. From 93, subtract 7. That will be 86, 79, 72, 65. So if the patient is able to do is able to get about 4 to 5 correct, he should get his 3 points. You can see it's over 3. Or he just made, is able to recall, is able to get 2 or 3 subtraction correctly, should get 2 points. If he's able to get only 1, get 1 point, he's not able to get any of the subtraction, 0 points. Then language, this is like a tongue tweezer. I only know that John is the one to help today. Yes, you ask the patient to repeat after you. The cat always hid under the couch when dogs were in the room. Patient should also repeat. Each will carry 1 point. That's over 2 in total. Then talking about fluency also, you should ask the patient to mention words that start with letter F. Should be able to mention up to 11 words. So, and it just carries only 1 point. And the patient should not list a proper noun. For example, the patient should not give response like Fatima or Florence or things or Fiona, names like that. There should be no proper noun. Only word that starts with letter F. So then abstraction. We can see there is an option of fruits, banana and orange. So you should put them, the person should put them in a category. We can see that their category should be fruits. When you talk about train and bicycle, they should be mode of transportation, or they should be things that have to do with wheels or things that move. Watch a ruler, they have numbers or measurements. So at least you'll be able to put them in a category or group. So this is where after all passing all these through difficult stages, then that's when you ask the patient to recall those 5 words that you have told him. Many patients, in fact, not even patients, even clients find it difficult to do some of these things. I remember there's a patient who is a banker and could not do this serial 7 subtraction. The patient was very, very disturbed because he could not do that, because he does this every day, calculations and so on. And that very day, when I subject the patient to mocha test, the patient was very worried. So then the orientation, we've talked about dates, months, year, day, place, city, and so on. Overall, the mocha test is 30-point score. If a patient has 26 and above, then it's normal. Less than 26 may have mild cognitive impairment and so on, till when it's having 0, it's having a severe cognitive impairment. But I think somebody raised a question here. So what is for those that cannot read and write? So additional point is added for those with less than 12 years of education. People with less than 12 years education means they have not, maybe they have just attended primary, they have not continued, they have attended primary, either started, completed, or secondary started, completed, or did not complete secondary. So you can put together that is 12 years. So for those with less than 12 years of education, you can add one point to them. However, there are other versions of this mocha test. There are versions that are usually pictorial. Person will just be able to identify certain objects or things and respond. So that's for those that are not educated. So going forward to the next slide is another form of assessment, which is the mini mental states, which I'm sure we are very much familiar with it. We can see it's almost the same with the MOCA test, except that MOCA is very much rigorous, is very much difficult, has a lot of domains, and even within a domain has a lot of many other questions. We can see orientation is the same. Orientation is the same as that of this. You can see registration, which is 3 here, but we have 5 MOCA tests. Attention, we have only serious 7. Subtraction, and here we have alternative spelling. You ask the patient to spell the word world backward. So just like the digit span test, so this one you have to mention DLROW in a backward order. Then memory, which are the 3 things you have mentioned above here under registration that you have to record. Then language also, and which we have similar to MOCA also is the visual spatial. Here you have to copy this polygon. But they also have the same scoring, which is over 30, and for many mental stage 20 score of 24 and above. That's when patient is normal and screening. Then we can go into details and assessing it. So between the two, sorry, these are not the only method of assessment of cognition. There are many others. We have ASA, we have mini-cog, we have other ones that can be used. But these are the most commonly used, yes. But among them, there have been a lot of researches have been conducted, and these have been reported. Among them, there's some, of example, MOCA test is more detailed, is able to dig in deep to find out more severe form of cognitive impairment, while many mental states may not go into that deep aspect. For example, there's been statement of certain neurologists that was saying you could assess somebody with dementia or mini mental state, and sometimes you could not be able to see that it's having a problem. So we have to choose wisely. What are we targeting? Then we now decide on which one to use. One has ceiling effect, one has bottom effect. These are common to all instruments. That there may be some, they have their own limitation. Of course, it's just like the usual test or assessment that we use for independence, that we check battle index. A patient can have a score. I have that experience of somebody having 100% score of battle index, but at the end, you see the patient is just that he has learned to use the unaffected side completely without the assistance of without combining the affected side. So he could tell you he could do everything without support, but it is using the unaffected side he was doing it. So that's why I said we have to look at the reason we're making our assessments. Then we have to also look at the psychometric properties, and we decide which one to use. So we'll now move to the next aspect or item of the assessing mood, or assessing mental state, of course. Yes. Well, we've talked about mood, which we talked briefly about depression. We have talked about the delirium. Well, sorry, we're going to talk about delirium. We have talked about cognition. I've talked about some other symptoms like the hallucinations and the delusions. Then we are now going to talk about delirium. We have said that also you could come through assessment and you have challenge that the patient is delirious. So what is this delirium? Is acute confusional state, of course. Patient will be confused, and it could be as a result of medical condition, surgeries, as a result of many conditions that could lead to this delirium. Yes, so you can screen using a confusion assessment method like CAM. Then you can go further to assess severity. One as of the DRS. Yes, the first one, the revised. We have the hyperactive type. Then they are very agitated. Yes, of course. Then we have the hypoactive type. This one, they have very decreased activity, low mood, and so on. In fact, most of the times it's been mistaken with depression, of course. Then we have the mixed type. They are in between the hyperactive and the hypoactive, and many instruments can be used to assess, as mentioned here. So we now come into the motor system assessment. Yes. The motor system assessment could be upper motor neuron, lower motor neuron, could be as a result of the nerve itself. We have mentioned earlier, it could be motor disease. It could be that of neuromuscular junction. Yes. So what are those features we usually see? Usually if it's of upper motor neuron lesion or type of injury, there is increased tone, of course. There is increased reflexes. There is pyramidal pattern of weakness, which is the weak extensors in the arm and weak flexors in the leg. Then lower motor neuron problem or lesions or injury, we usually see wasting and fasciculations, decreased muscle tone, or we have usually see impaired or absent reflexes. At the neuromuscular level, we usually see muscle easily got fatigue, normal or decreased tone. We usually see normal reflexes. So assessment of motor system. We have muscle strength, muscle power, which assess the various muscles in the body. The strength, we have the muscle tone, coordination, reflexes, and many others. So we'll be looking at this one after the other. So starting with muscle tone, yes. It's a natural condition in which skeletal muscle stays partially contracted at all times. So even at resting stage of muscles, they are still partially contracted, except if the muscle is completely denervated, yes, then there will be no tone. Of course, we'll see flaccidity and atonia. So muscle tone provide a slight tension on the muscle to prevent damage to the muscles and joint from sudden movement. That sudden movement, at least there is still some level of protection. It also helps maintain body's posture. So all muscles have some amount of muscle tones if they are innervated, of course. So patient is relaxed. When there's going to be assessment, the patient is relaxed. But the moment you give instruction to the patient that you need to relax, that's when you will now elicit, that's when the patient will now become tensed. So you now find it difficult to make the patient relax. So you just have conversation, you just follow the conversation. You just have to explain to him that you are taking some neurological assessment in general, yes. So without his knowledge of So basically what will be done, because when the time you begin to ask him, relax, then that's when you start seeing the patient becoming more and more tensed. So when assessing the arms, the tunes from the arms, what do we do or how do we do it? You just assume shaking hand position, just like you are shaking hand of a patient. Then you hold the forearm. So you hold the forearm with your other hand when you are holding the hand, and the other one you are holding the forearm. So you supinate and pronate the forearm. You circumduct the wrist, you flex and extend the elbow. So you feel if there is any resistance coming up through the movement. So while assessing hip, what do we do? Patient is lying supine, of course. You hold the patient at the knee in neutral position. The knee is in neutral position. Then you begin to roll the lower limb, like going into internal rotation and external rotation. You just roll the knee, which will take the hip into internal and external rotation. Then you feel if there is any resistance. Then knee joint, assessing muscle tone at the knee joint. You place the hand behind the knee of the patient. You lift it rapidly and watch the hip. Hold the knee and ankle, flex and extend the knee when you check. Then the ankle also, you hold the ankle, you dorsiflex, you plantar flex. Then you find out if there is any resistance through the movement. What you usually see is a slight resistance through the whole range of motion. It's not like it's intermittent, it's throughout. It's resistant throughout the whole range of motion. So that is normal. When it's decreased, you feel there is loss of that resistance throughout the range of motion. It's like, you remember, it's like you are flinging the limb through the movement of the joint. Then when there is increased resistance, suddenly, it will increase, and so that's when you have spasticity, and there are various ways to assess spasticity in which we have various instruments like the Ashworth scale, the modified Ashworth scales we can use to assess. So the resistance is increased through the whole range of motion. That's when we have rigidity, which you usually see in a Parkinson's disease patient or Parkinsonism. Yes. So reflexes. We have we're looking at deep tendon reflexes. Of course, there are other reflexes. So superficial reflexes, there could be assessed cremasteric reflexes, assessment for main anal reflexes, and many other things. We are focused here only on the deep tendon reflexes. We can assess the bicep tendon reflexes, the triceps, the knee reflex, jack, the ankle reflex, and many other ones. We have the hand and many other areas we can assess, the supinator as well. So what do we see? We see areflexia when there is no any response, or we see hyporeflexia, nomoreflexia. When it's excessive, we have hyperreflexia. So when taking reflexes, we should use the whole length of the patellar hammer, not just certain length of the hammer. So we should hold the hammer at the end, at the tail end of the handle. Yes. The same thing, you try not to tell the patient to relax, because by the time you tell the patient to relax, that's when the patient will become tensed. So all the joints should be placed at the muscle should be at 90 degrees When sometimes the reflex is not too visible or is not revealing, so you have to use some maneuvers to reinforce, which will make it visible very well or much visible. For example, in the upper limb, you ask when you want to use some of the maneuvers to make it more pronounced. If you are taking upper limb reflex, for example, you ask the patient to clench the teeth, then this will help in the pronouncing, will help in revealing the reflex more. Then if it's that of lower limb, you ask the patient to make a fist. Yes, or you ask the patient to hold hands across the chest. This is just an example. You ask the patient to hold the hand across the chest, pulling the hand, pulling each of the hands apart, just like this. Then that is this will help in making the lower limb reflex more pronounced. For the upper limb, you ask the patient to clench teeth. Then the lower limb, either you ask them to make a fist or you ask them to hold the hand across the chest and pull against each other. So that's just one example that you can make some maneuvers to make the reflex. Various reflexes assessment. To start with the biceps. Yes, place the patient's hand on the abdomen, such that the elbow is at 90 degrees. Then you place your index finger on the biceps tendon. Then we swing the hammer on the you swing the hammer on the on your finger. Then for the triceps, you draw the arm across the chest, holding the wrist. Yes, then the elbow is at 90 degrees. Then you strike the triceps tendon with the hammer at the triceps tendon, of course. Then for the knee, which is the most common one that we usually do in our clinics, place your arm under the knee. Yes, the knee should be at around 90 degrees. Then you strike the patella just, you strike at just below the patella. Then that of the ankle, you hold the patient foot at 90 degrees so that the medial malleolus is facing up or the ceiling. Then you strike on the tendon, yes, the TE, then you see the response. There are various ways to assess the ankle from different positions. So because of time, you know, assessment of muscle strength will take, I think, the whole day, because taking each of the muscles in the body. So that's why I think I've said it in the earlier at the beginning that there are some topics that we're not taking. I think there are common things we do in the clinic. Muscle strength assessment. I think this is one aspect that I didn't take under the motor system assessment. So the sensory system assessments, we have various types, many: proprioception, vibration sense, temperature, light sensation, pinprick or pain sensation assessment, double stimulation, light touch, many other 2 points discrimination, and many other ones. So just take through few of them and see. So starting with proprioception. Usually you start from distal, the smaller joint, to the proximal, to the larger joint. Compare with right and left. I've mentioned earlier at the beginning and in the introduction that we could be comparing with right or left, with normal side or with the unaffected side, or sorry, affected side, unaffected side, and so on. But first of all, we need to demonstrate to patients what we want to do. So starting from, that's at the upper limb. When we are starting the assessment of proprioception, we start with the fingers. Yes. So you hold the distal phalanx between your two fingers. This is just an example. You hold, your fingers are at 90 degrees to the direction. So you show the patient this is how you are going to move up, down, up, and down. So the patient is going to feel the movement. After that, then you take through the assessment and ask the patient. You flex and extend. So you tell him that you will now ask if the joint is extended. You ask him, is it up? He'll tell you, while the eyes are closed, of course. You ask him, is it up or is down? He'll tell you. If you take it down, you ask him, is it down or up? He'll tell you. Then if it's intact, you move to the neck joint. You move to the wrist. You move to the elbow, and so on. So you start from the smaller joint to the larger joint, of course. So starting from the smaller joint is the distal phalanx or the toe. You move it, you go to the wrist, you go to the ankle, you go to the knee, you go to the elbow. You move through the, you start with small range. You ask the patient whether the joint or the position of the hand is up, that is flexed, or is down, or is extended. So the patient should be able to tell you while the eyes are closed. Then you start from large range of motion, then reducing the range of motion, because when the range of motion are smaller, they are more difficult to detect. So you are making it from simple to difficult task. Yes. So vibration sense. Vibration sense is usually assessed using the tuning fork, of course, of 128 Hz. Of course, there are different other frequencies, such as 250. We have others of over 250, and we have up to 500, and so. But the best one to be used is that of 120 for assessment of vibration sense. Yes, the procedure is to demonstrate to the patient. I'm going to demonstrate it. For example, this is the tuning fork, this is the base, and these are the prongs. So you just hit the prongs and place the base, the base of the base of the tuning fork on the bony prominences of the patients. So you could start also from smaller joint also to larger joint. So after striking the tuning fork, you can place it on the bony prominence points of the smaller joint. You can place it at the other bony prominences. You can go on like that. You can start also when assessing the lower limb. You can also start from the toes to the malleolus or the different malleoli, then upwards to the anterior iliac spine, and so on. So you can demonstrate to the patient that this is what is going to feel. Going to feel some buzzing sound, and you are going to place it on his bony prominence. He's going to feel the vibration. You're also going to look at the patient and see how he's responding. So just to make sure that he's feeling the vibration and is giving you the response, you can strike it and place it while it's vibrating. Then it's going to give you a response that, yes, I'm feeling the vibration. Next time you can do it and place it and at the bony prominence, of course. Maybe the third time you are striking, you stop the vibration and place it. Then you are going to, then if it's trying to manipulate the response. He could tell you that, yes, he's still feeling the vibration while you have stopped the vibration already and you have placed it without any vibration. So you could know that, yes, he's having some problems, some neurological problems, of course. Then temperature, of course. Using the tuning fork also, because the tuning forks, most of the time, because it's metallic, you could feel that it's very cold. You can place it on the patient's hand or feet, and he will tell you that he can feel, yeah, it's cold. Yes, then that's like a screening. You want to further do that, you can also start from distally to proximally, the same with other assessments. So you can also use the test tubes. Just the test tubes. Make sure when you are buying the test tubes, you are not buying a sample bottle. Yes, so you get the test tubes. One is filled with warm water and one with cold water. But you can see a temperature of less than 5 degrees can cause pain, and more than 45 degrees can also cause pain. So they shouldn't be beyond this temperature for the hot and the cold. So the two test tubes are applied at the interested areas that you want to assess. They tell the patient whether he's feeling hot or he's feeling cold. So he's going to respond to you. So of course, it's going to do it with eyes closed. So that you apply hot alternatively or randomly, you apply hot or cold, and it's going to respond to you that what the specific temperature is feeling, whether it's hot or it's cold. So 2 points discrimination. 2-point discrimination, yes, the instruments could be, there are various types, of course. Some use compass. Compass may be very painful and patient could get injured. And there are other instruments that could be assessed, that could be used. Yes, that's are of various lengths apart from each other. The prongs, yes. So what is needed is you have to place either one prong or 2 prongs. Then patient should be able to tell you that it's, one prong is feeling or 2, and simultaneously like that. Yes, and there's a certain distance for each of the body parts for when you are placing 2 prongs. And while assessing 2-point discrimination, one should be cautious of also the nerve distribution that are supplying the various skin parts, because one prong, if one is not careful, one prong could be in a territory of another muscle, and the other one will be in another muscle, another nerve. Sorry. So we need to take that into consideration. Then stereognosis, of course, is the ability to identify the shape and form of 3-dimensional objects, and therefore its identity and manipulation. So patient will be asked to close his eyes and will be given certain objects, such as objects that one is familiar with, of course. You can decide to give something that somebody is not aware of, and he is not able to tell you what that is, and you score the patient, and you say the patient has a problem, has a stereognosis. So that could be wrong. So something that people are familiar with, that they use every day. It depends on the environment, depends on the country and places. So I give, let's say, comb, keys, pen, and so on, and ask the patient to identify them. Then after identifying them, then patients, of course, with eyes closed, then that means the stereognosis is intact. Then graphesthesia, yes, ability to recognize symbols written on the skin. The symbols could be in the form of letters or in the form of numbers, of course. So patient could write letters on the hand of the physiotherapist, sorry, could write letters on the hand of the patient, and the patient should be able to say them, or to write the certain numbers on the hands of the patient, and the patient should be able to respond. For patients, let's say they have a speech problem, which you have mentioned, there's going to be a speech problem. Of course, you can show pictures of those letters or numbers written. Then the patient will identify that this is what he has perceived that was written on his hand, or on his or her hand. Then assessment of pain or pinprick. So using a disposable pin, safety pin, or dressmaker's pin, or any of them, whichever one, it should be it should be clean. Yes, it should be aseptic procedure. After using it on the patient, it should be discarded, of course. Should demonstrate to the patient that the sharp end is going to be used, and also the blunt end is going to be used. So the patient should be able to tell if it's a sharp end or the blunt end. So the patient will be asked to close his eyes, and random stimuli will be applied, either sharp or blunt. Then the patient will now respond that this is what he is feeling. So this is about checking pain. There are many other things like the light touch, in which people use cotton wool, of course. Cotton wool is used to assess and touch various areas of the skin, and the patient should respond which area was touched. Yes, about the sharp end. That's why I said it's a safety. It has to be a very safe procedure. After that, it will be discarded, and you have to make sure you have not injured the patient, of course. Then double stimulation, in which various body parts are being, the two body parts, right and left, are being touched simultaneously, and the patient should be able to respond which of the body part was touched. Then there are other assessments like the Lamite sign. Sorry, it's a French name. I don't know if I pronounce it properly, but that's the test. So forward flexion of the neck produces a feeling of electric shock running down the back of the patient. So sometimes it could be spontaneous. Even while the patient is sitting down, there is electric shock feeling at the back of the patient, or sometimes through neck flexion. Then it elicits such a problem. It indicates usually cervical pathology, cervical cancers, and many other problems in the cervical region, of course. We have the autonomic nervous system, which know that the autonomic nervous system is responsible for various activities in the body, of course, and this helps in maintaining stability in our normal day-to-day activity. So we know that the sympathetic system is the alarm system. It helps during the response to threats and so on. Then parasympathetic, like the holiday system, which is the opposite. So, and there are various ways to assess using the pulse rate, the BP. We can check the pupil constriction and dilation, bladder function, when there is urine retention, when there is incontinence, restriction of sweating, excessive sweating. Different problems will indicate bladder and bowel function. Different problems of bladder, of course, such as the urgency or retention. Then the maybe probably impotence is also one of the things that we could see. Then urine retention, also another problem that we could see. Then skin also could be observed for sweating, is able to sweat or is excessive sweating. Change in BP while we are changing our position also. For example, resting pulse, the normal range is usually 60 to 100, of course. So when there is tachycardia, we should know that probably there's a parasympathetic abnormality. Then when heart rate responds to standing, in the first 15 beats, you are recording first 15 beats. The increase normally should not be more than 11 minutes per, more than 11 per minute. So when there is increase, when there is loss of response of this, usually when you stand, then there is going to be this difference or increase. So when there is loss in this response, then usually the parasympathetic is abnormal. Then BP respond to standing. Usually it falls, the systolic pressure falls at around up to 30. Then you should know that there is probably sympathetic abnormality. So other assessment like meningeal irritation, problems that have to do with the meningitis, many other conditions. So you place your hands behind the patient's head and gently rotate head side to side. You check if there's any resistance while rotating the head. Then another test is you can gently lift the head off the bed, then feel the tone in the neck. So you watch the legs for hip and knee. So when you have hip and knee flexion, that's the Brzezinski sign, which indicates meningeal irritation. We have the Carney sign. From the Brzezinski sign, you can go further to assess with Carney sign, which in the lying position reflects the leg at hip with knee extended, then trying to extend the knee. When there is resistance to such movement, then there is a sign of meningeal irritation. Then we have the health jolt test. Ask the patient to turn his head horizontally at a frequency of 2 to 3 times per second. When it worsens the symptoms, let's say headache and other things, then now also confirm that it's meningeal irritation. Then consciousness, we also said that there is also challenge in assessment of unconscious patient, but there are a lot of other ways to assess the positioning. Of course, will tell us a lot. Apart from assessing the level and severity of coma, will tell us the severity of the condition using, let's say, glaucoma scale, glaucoma outcome scale, and the positioning also we check the cerebrate position, the corticate position, and many other things will also tell us the problems.
Dr. Bopo, I think you muted yourself. What happened?
Hello, Dr. Samadi, can you hear me? I was just discussing with Hafiz that if we can go for a break and come back.
Okay. Okay, how many minutes?
Yes.
How many minutes?
Uh,
How many minute break? Hello? So just hold exercise patient, please. We are having some technical hitches, but we're having some little break. A few minutes. Just wait, hold on for some time, please. Thank you.
Hello, good afternoon. Please, can we have some 15 minutes break?
Okay. But please make it 15 minutes.
Okay. You will be back in 15 minutes, inshallah.
as much.
Sorry, the presenter will soon join and continue. Sorry for the waiting. Yes.
Good evening, everyone. We are back. Hello?
Yeah, you are on. You are on.
Okay.
You are on.
So we stopped at, sorry, we are starting at the assessment of coordination. Yes, you can continue. Assessment of coordination. There are various ways to assess, ranging on from the upper limb and the lower limb. Starting from the upper limb, you can use the finger. We can administer the finger to nose test, which is a test that we ask the patient to touch his nose from outstretched hand. So the physiotherapist will stand in front of the patient at a distance of arm length. Yes, the physiotherapist will instruct the patient to touch his hand. For example, you are standing right in front of the patient with your hand stretched. Then you ask the patient to touch your fingers. Yes, so you watch the quality of movement of the upper limb. Yes, that's what I'm trying to demonstrate. You are standing in front of the patient with your hand stretched. Then you ask the patient to touch your fingers while he's seated, while seated and facing you. Then you stretch his hand to touch your fingers and touch his nose and like this, while you are watching and while observing the quality of movement. So you can ask him to repeat the movement faster. When he's making it faster, then you also watch the quality of movement while he was doing it. For some patients, if the quality of movement is worse and you are scared that they could injure themselves, you can ask them to touch their ears instead of coming down to touch their nose. You can ask them to touch their ears, because some may go straight to their eyes and probably they could get injured. So that's finger to nose test. Then we have the heel to shin test. In this particular test, you ask the patient to take his heel to the opposite knee. And while he's lying supine, of course, then you ask him to slide down the knee on the shin, sharp end of the shin, that's the tibia, downwards to the foot. And you observe the quality of movement. If he's able to do it and it's not dropping and other things, then he has a good coordination. You should not allow the patient to slide the foot down and he's moving not on the tibia. He has to do it on the shin, on the tibia. Then the trunk test, it also tests for coordination. You ask the patient to sit up from lying supine without support of the hand. So is the patient going to one side or to the other? Then there's also a problem with coordination. So there are other aspects of testing coordination, which are repeated movements. For example, you can ask the patient to to repeat movement by touching, using his tongue to touch the other fingers. Can do it slowly and faster to make it more difficult. Ask the patient to supinate and pronate, and ask him to demonstrate like using a key to open a door or door hand, or use a close or things like that. So repeated movement also could be done using the lower limb by asking the patient to plantar flex and just flex, and do it slowly and faster also. Can also do it bilaterally using the two lower limbs also. Yes, so those are some of the examples of the repeated movements of the upper limb and the lower limb, of course. Then balance. We have limit of stability. If we go beyond that limit, we fall down. Yes. So all the time, most of the time, tests for balance happen to be tests of risk of fall. Yes. If we want to engage our patients in standing or involve them in gait activities or mobility, we have to test their balance. We have to test if they can move around and be able to perform such tasks. Sorry, a comment I just read. Yes, so yes, somebody posted that this is Michael Jackson style. So I think Michael Jackson was going beyond the limit of stability. So I think it's up to us to find out how he's able to do it. Maybe this is a recorded session, and so I don't want to discuss that. So we can go further and see. But this is actually going beyond the limit of stability. What is the limit that we can go and we cannot go beyond? And beyond that means we are going to fall down. We cannot go forward more than 8 degrees, and to the side we cannot go more than 8 degrees also, and to the back anything more than 4 degrees one will fall down. So this is almost 45 degrees or so, I think. So what happened next? One will fall down. So what are the various tests of neurological examination we can deploy for assessment of balance? We have the static balance, we have the dynamic balance. Dynamic balance, they come hand in hand with gait or mobility. So let's start with the static balance. First of all, we have the step test. Yes, we count the number of steps that one is able to do while standing on one leg and the other leg on a higher platform, like the steps we have usually in our gyms. But there is a standard. I think we should check in our gyms. The standard for those steps are supposed to be 7.5 cm high. On the other side, it's supposed to be less than, because we have two sides of the steps. The other one is higher, the other one is lower. So the higher one is supposed to be about 7.5 cm. That's the standard. So we are supposed to assess how many steps one will be able to do in 15 seconds, and going through a height of 7.5 cm. So the person will have to do it as fast as possible, taking his or her foot up and down, up and down, up and down a step while standing at the edge of these steps. So there are a lot, like I said, there are a lot of values and variation for all these tests we do. I usually take caution in giving values for each outcomes, because we have stroke patients. We have to assess the affected and the unaffected. We may be testing for screening. We will be testing for further assessment. So the normal steps are 10 steps, but for stroke patient, they go much beyond, especially for the affected upper limb, lower limb, sorry. Then the run back test is just a patient standing, and it could be that you can ask the patient to take his arm up, as you can see on the picture, or it could be by the side. You can start by standing erect and taking the hands to the side only, then asking the patient to close his or her eyes. Then you can make it more difficult by asking the patient to raise the hands up to 90 degrees. So if the patient is able to endure it without falling down or swaying for 30 seconds, then so for the step test, I think that's the question that was posted now. For the step test, we are supposed to assess for affected side while the patient is standing on the affected side, and one is also standing on the unaffected side. So we assess both. This number of steps is for normal individuals, not for the stroke patients. Sorry. So run back test, 30 seconds, then patient is okay. If it's swaying and almost falling down, then it's failing the test. Then it means there's going to be risk of fall when it's involved in any mobility. Then one leg stance. Patient is asked to stand on the preferred legs, hands on the hips, eyes open, maximum of 20 seconds, and patient is not swaying or struggling to stand and almost falling down, then patient is good to go. Then time up and go, which is a test for dynamic balance, which we have is assessing also risk of fall and possible mobility. The patient is asked to stand from a chair. The standard is an armchair, so the hands will be on the arms. The hands will be on the arms of the chair, and there will be 3-meter walk mark on the floor. The patient will ask to go around and come back to the length of that 3 meters and come back and sit. So the patient is timed from the moment he stands up from the seat and walk around. When he engaged in sitting, you stop the timing. Usually 10 seconds, but for stroke patient, it's usually higher, up to 15 and 20 seconds. It depends on the level of severity. Sometimes it could be used with assistive devices. It could also be administered with orthotic devices. It depends on the level of the patients. Yes. So tandem stance. This is a measure of static balance. The patient will stand with one leg in front of the other and will stand for about 15 to 30 seconds. When the patient could not withstand the standing for less than 10 seconds, then there is risk of fall. So you demonstrate to the patient and you support the patient around because of risk of falling. So if it's able to do it, then it has a good balance and can be engaged in some activity. Then the Fukuda test. This is just like a step test. It's just like the step test, but this one with 2 legs or 2 feet instead of 1 feet. So the patient will just like marching, like the military marching or the police marching. So after completion, the patient will have to complete 50 steps. So after completing the 50 steps, we do it with eyes closed. By the time the patient opens his or her eyes, if you see that he has rotated from the position he has started the steps. So up to 30 degrees of rotation is okay, but more than that, then there's a problem. Then the functional reach test. After the functional reach test, the patient will stand erect and will reach out. The arm will be at 90 degrees, then we reach out without stepping. So the patient will not step out within its base of support. Then there will be measurement of where the patient starts and where the patient ends. So up to 25 cm, there is a good balance. So there is also modification of this type of test could be lateral, and it could be forward. This is the forward test, forward functional reach test. We could have the lateral. For example, we ask the patient to reach out to the side. This is reaching out to the side. What we have here is the forward. The person is leaning forward, but within the base of support, we lean forward. But the lateral will go to the side, and measurement will be taken using the tape, of course. We have the tandem walk test, just like the tandem stance, where one foot is in front of the other. Then we have the tandem walk. In this test, the patient will have to walk up to about 8 steps or 10 foot line. That's heel to toe, heel to toe, heel to toe. Then if there are errors of up to four steps, then there's a problem with balance. Yes. While you are watching the patients assessing the balance, there are a lot of strategies that you see patient will deploy not to fall down. We have the various strategies. We have the ankle strategy, which is for the very strong patients. Yes, they will only move at the level of the ankle, but the force is becoming more intense. The activity is becoming more difficult. They will have to deploy the hip strategy. Then that's when somebody will have to come up with the arms to balance up. Then the next thing is patient will fall down. So have to watch carefully. Then we have gaits. We have different types of gaits. The gait cycle that we have to apply. We have to check various movement patients do will translate to what type of gait is, hemiplegic gait or high stepping, Parkinsonian gait, ataxic, antalgic, and various types of them. So what do we check? We check the arm swing. Is it automatic, or they are just matching like military or like robots? Is the trunk symmetrical? They are not going to one side, like in the case of hemiplegic gaits, like there asymmetry. Is there the trunk rotation while they are ambulating, the hip movements, the knee, the ankle, the various cycles of the gait? Are they okay? Yes, the ranging from the heel strike, the position of the foot and the toes, the knee, the ankle, the hip, the trunk also, because while we are walking, there's some level of trunk rotation, and this is what most time in the stroke rehabilitation or neurological rehabilitation is applied in the proprioceptive neuromuscular facilitation technique, the trunk exercises, or and the Bobart concept also. These trunk exercises are also involved, which will have to involve patient in trunk rotation and trunk rotation mostly, yes. So the other parameters you have to assess: stride length, step length, gait speed, and many other things. How the patients ambulate using the assisted devices, and we need to also, if the ambulates normally, we need to also make the ambulation more challenging, that's when we'll have to see we'll have to reveal other problems. For example, asking the patient to work on heels, asking patient to work on toes. You're assessing the strength of the lower limb muscles and different topography, different compliance of the floor. For example, asking patient to work on a tiled floor or working on carpets, they will have to work differently. Yes, if they have problem with balance, because when they work on tile, they have to work carefully and not to fall down. When they walk on carpet, it's a bit, there is much friction, so they might not be scared of falling down. So it's just like putting a patient also in a wobble board or on something more compliant or something very compliant also. So that would also make the assessment more challenging. So many other things can be done. So from the assessments, you also need to synthesize what could be the possible problems after your hypothesis, and you're thinking of possible outcomes. These are the possible outcomes of assessment. So when you have weakness of all limbs, individual or patient having weakness of all limbs, what could be the possible reasons for such? When there is upper motor neuron pattern, yes, hyperreflexia and many other things we have mentioned. It could be cervical spine, it could be cervical spinal cord injury, or bilateral brainstem injury, or bilateral hemisphere, or let's say bilateral stroke. Yes. Or the pattern is not that of upper motor neuron. So it could be myopathy if the proximal is greater than the distal, but there is no sensory loss. Or it could be neuropathy if the distal sensory, if there is a distal sensory loss. Yes. So weakness in both legs. If it's a upper motor neuron pattern, of course, then we have a spinal cord injury, usually thoracic and above. If it's of not upper motor neuron pattern, then usually myopathy, if proximal is greater than distal, just like you have mentioned, the tetraplegia or paraplegia, and neuropathy with distal sensory loss. If it's unilateral arm and leg, then there is lesion in the brainstem or hemisphere. But we have to look for associated signs. It's not just that there is this and that, but it's just a hypothesis. So you dig further that it could be so condition. Okay, what are those conditions under this umbrella? Then you begin to screen them one after the other. If it's a single limb, upper motor neuron pattern, then it's radiculopathy. These radiculopathies are usually single nerve abnormality, which may be a result of cervical or lumbar disc protrusion, or polyradiculopathy, which indicates lesions to many roots. It produces more proximal weakness, for example, within GBS, mononeuropathy, which you have a nerve abnormality, which is usually due to entrapment of nerves or compression. So it's different from peripheral neuropathies. Then we have polyneuropathy or peripheral neuropathy, which is usually abnormality of peripheral nerves, which is as a result of most times diabetes mellitus is one of the commonest reasons. Hypothyroidism, vitamin deficiencies such as B1 and B12. Then myopathies, usually we have muscular dystrophy, which is inherited, inflammatory such as polymyositis and dermatomyositis. Then endocrine, usually steroid-induced hyperthyroid and hyperthyroidism or hypothyroidism. Then toxic, usually alcohol, statins, and chlorine. I forgot to mention also there's another type of delirium, which is the delirium tremens, which is usually caused by alcohol consumption. Yes. So in the sensory assessment, sometimes there is a glove and stocking a deficit at the hand, around the hand, just like wearing a glove. There is a sensory deficit there. And just like wearing stocking, also around that area, there will also be sensory deficit. So they're usually polyneuropathies with such problems. This comes to the end of the short lecture, of course, because there are many things we have not talked about. Cranial nerve assessments, which is a very big topic, which cannot be covered, I think, even in one day. Then myotomes and dermatomes, which are very important to for any neurologist or neurophysiotherapist to look into while managing patients. And of course, we have mentioned the basics of anatomy, physiology, pathology of the conditions are very, very important. Thank you very much, and thank you for your time.
Thank you, Dr. Wapa, for the presentation.
Okay, thank you, sir.
I think if we have questions, I know time has already passed. Few questions, if there are, and comments, please. Okay. I think virtually we don't have a question. I don't know whether in the comment section whether we have some people that let me check.
Okay, thank you. Thank you very much. If there is no question, I'm glad to be here. And thank you for your audience once again. Your feedback is also very, very important. I think I will have to get the feedback from the coordinators.
Okay, thank you so much, sir.
Thank you very much.
We thank everyone for participating in the session. Looking forward to next week, where we will be majorly looking at imaging, neuroimaging, all through next week. So thank you all, and see you next week.
Have a nice day.
Yes, thank you.
Thank you, everyone.
Yeah. I think Hafiz, we can leave, right?